Alright, starting with obstetrics uh, from 428 to 466. Okay. The basics of pregnancy. The terms and concepts that follow are central to an understanding of the physiologic processes of pregnancy. Gravidity, that's number of times a woman has been pregnant. Parity, that's number of pregnancies that led to a birth beyond 20 weeks. Gestational age, or an infant weighing more than 500 grams. In prenatal assessment, TPAL expresses the number of term deliveries, the number of preterm deliveries, the number of abortuses, and the number of living children. Okay. Embryonic age, number of weeks plus days since fertilization, usually unknown. Gestational age, the number of weeks and days measured from the first day of the last menstrual period, LMP. GA can also be determined by the following. Fundal height reaches umbilicus approximately 22 centimeters at 20 weeks, plus 1 centimeter per week of gestational age thereafter. Okay, so reaches umbilicus, fundal height, okay. Approximately 22 centimeters at 20 weeks. Okay. 1 centimeter plus. Okay. Fetal heart tones, Doppler, typically 10 to 12 weeks. Okay, so that's when you start hearing that. 10 to 12 weeks, okay. Quickening or appreciation of fetal movement occurs at 16 weeks for multiparas and 20 weeks for primiparas at the earliest. Ultrasonography, that's most accurate dating method in early pregnancy. Fetal crown rump length, CRL, at 6 to 12 weeks. Preferred measurement from 13 weeks plus. Biometry using biparietal diameter, BPD, femur length, FL, and abdominal circumference, EC. Key fact here is a G3P1 patient has had 3 pregnancies but only 1 birth beyond 20 weeks, and or an infant who weighs at least 500 grams. Okay. Diagnosis of pregnancy. Beta human chorionic gonadotropin, or beta HCG, the standard for diagnosing pregnancy, can be detected in serum or urine. Serum beta HCG, more sensitive and preferred if menstrual period is less than 1 week late. Produced by the placenta, peaks at 100,000 MIU per ml, million international unit per ml, okay, by 10 weeks. Okay, it decreases throughout the second trimester, plateaus in the third trimester. Beta HCG levels double approximately every 48 hours during early pregnancy. Failure of HCG levels to double every 48 hours concerning for miscarriage or ectopic pregnancy. Okay. So it's produced by placenta, peaks at that by 10 weeks, serum beta HCG. More sensitive and preferred if menstrual period is less than 1 week late. And the standard for diagnosing this can be detected in serum or urine. Okay. Get a quantitative serum beta HCG, key fact, to help diagnose ectopic pregnancy and follow the trend for resolution after treatment, to help diagnose miscarriage, to monitor after treatment of trophoblastic disease, rising levels concerning for choriocarcinoma, to screen for fetal aneuploidy. Okay. So all of these can help with that. Ultrasonography, used to confirm an intrauterine pregnancy. Gestational sac visible on transvaginal ultrasonography by 5th week. 5 weeks. A beta HCG in the range of 1500 to 3500. Transabdominal ultrasound, typically reserved for second and third trimester measurements. Okay. Physiologic changes in pregnancy. Okay, so this table describes the physiologic changes and seen in pregnancy as well as their mechanisms. These changes occur to increase perfusion to the fetus, optimize maternal fetal gas exchange, and alter the maternal pelvis to aid in delivery. Okay, so these are the physiologic changes in pregnancy, system changes, and mechanisms. In CVS or cardiovascular, stroke volume increases to maximum at 19 weeks and then plateaus. Heart rate gradually increases 20%. Cardiac output rises rapidly by 20% and then gradually increases an additional 10% by 26 weeks. Peripheral vascular resistance progressively decreases to term. Blood pregnancy gradually, Blood pressure gradually decreases 10% by 34 weeks and then increases to pre-pregnancy values. Okay, so blood pressure gradually decreases 10% by 34 weeks and then increases to pregnancy values. Okay. So peripheral vascular resistance progressively decreases to term. Okay. Peripheral venous distension progressively increases to term. Okay. The increase in stroke volume may cause physiologic systolic flow murmur. So mechanism is stroke volume plus increase in heart rate leads to increase in cardiac output. Okay. Increase in progesterone leads to decrease in peripheral vascular resistance, which leads to decrease in blood pressure. Okay. Circulatory blood volume increases by 50% in the second trimester. Fibrinogen increases. Hematocrit decreases slightly. Decrease in platelet count. Okay. Changes. I'll do that again. Blood volume. It increases by 50% in the second trimester. Okay, that's easy to remember. Fibrinogen increases. Okay, you gotta remember that one. Hematocrit decreases slightly because there's increase in blood volume. Okay, decrease in platelet count as well. Okay, so I guess they're trying to reduce the clots basically, and clotting factor to prepare for the labor, I guess, for the delivery to avoid. Okay, yeah, I guess. So increase in fibrinogen and decrease in platelet count. Okay, so increase in fibrinogen factor 7 and 8. Okay, uh, plus a decrease in. Oh, okay. So they're increasing clotting factors. Okay, they want the clotting factor. Okay, got it. And decrease in protein S. This leads to hypercoagulable state. It decreases intrapartum blood loss risk, right? To reduce the hemorrhage risk during delivery. Okay. Uh, Plasma volume increases uh, more than increase in RBC. So this leads to decrease in hematocrit. So this is dilutional anemia. Pulmonary changes. So tidal volume is going to increase because you gotta um, bring out the CO2 as well from the fetus as well, uh, in addition to the mother's own CO2. Okay, so tidal volume increases to keep up with that demand. Respiratory rate, vital capacity unchanged. Expiratory reserve, gradual decline. Okay, so there's a gradual decline in the expiratory reserve. I guess because there's abdomen pressing onto the diaphragm, which presses onto the lung, so there's a decrease in that, I guess. Um, okay, so vital capacity still is unchanged though, and respirate rate is also unchanged. Respirate rate is unchanged. I thought it increases. If tidal volume increases, okay, I guess. Okay, makes sense. Uh, dyspnea due to pressure from uterus. Respiratory alkalosis with metabolic compensation. Progesterone mediates an increase in tidal volume and alveolar ventilation. Renal, uh, okay, so dyspnea due to pressure from uterus. Okay, so, okay. Respi alkalosis, so with metabolic compensation. So progesterone mediates an increase in tidal volume and alveolar ventilation. Okay, so there's going to be CO2 washout then. That's what's causing the alkalosis, I guess. Renal flow increases 25% to 50%. GFR increases early and then plateaus. Decrease in serum creatinine and blood urea nitrogen. Hyponatremia 4 to 5 milliequal per liter, below pre-pregnancy levels due to dilutional and increased antidiuretic hormone secretion. Increase in urinary frequency and glucosuria as well. Yes. So renal flow increases, GFR increases, serum create decreases, and so does BUN. They both decrease. Hyponatremia due to dilution, increase in urinary frequency, increased ADH as well. And, okay, hormone as well. Okay, and increase in urinary frequency. Okay. GIT, gastrointestinal, decrease in esophageal sphincter tone, plus increase in gastric emptying time. Uh, this leads to reflux. Okay. Um, Decrease in GI motility leads to constipation. Yes, that was a side effect of, was it uh, progesterone, I think? Uh, Let me check. Right, so in pregnancy, increase in progesterone leads to decrease in LES tone, decrease in colonic smooth muscle activity, and decrease in gallbladder motility as well. Okay. Also, estrogen, it increases the cholesterol secretion into bile as well. Okay. So because of the decrease in gallbladder motility, you will have increased risk of cholelithiasis as well. Okay. Um, okay. So again, decrease in esophageal sphincter tone, increase in gastric emptying time leads to reflux. Decrease in gastrointestinal motility leads to constipation. Decrease in gallbladder motility leads to gallstones. Decrease in um, venous return, hemorrhoids. Okay, leads to that. Okay. Musculoskeletal, low back pain, common in third trimester, caused by increase in pressure from the uterus and laxity of muscles and joints. Skin, chylesma or melisma, patchy brown discoloration of the face, linea nigra, and nipple hyperpigmentation. Okay. Uh, Physiologic changes and this continued system change mechanism, endocrine, progressive increase in estrogen, progesterone, and um, prolactin. So increase in beta HCG, uh, peak at 12 weeks and decrease until plateau uh, reached at about 24 weeks. Okay. So increase in beta HCG peak at 12 weeks and decrease until plateau reached about 24 weeks. Okay, so there is progressive increase in estrogen, progesterone, and prolactin, and there's also increase in total T3 and T4 and decrease in TSH due to increase in negative feedback. Okay, see this table, I guess, and mechanism. So thyroid binding globulin levels increase in response to estrogen and pregnancy. Most T3 and T4 circulate bound to TBG, so the T3 and total T4 will also increase, but the levels of free T3 and T4 will not change. Most T3 and T4 circulate bound to TBG, so T3 and total T4 will not will also increase, okay, but the levels of free will not change. Okay. Prenatal care and diagnostic testing. Okay. Before that, let's look at this. So, effect of pregnancy on pituitary thyroid axis, HCG. Is that? Okay. So we have anterior pituitary releasing TSH, and then that goes to thyroid, increases total T3 and T4, which in turn goes to the anterior pituitary for the negative feedback to stop it. Increase in HCG activity will cause thyrotropic activity, stimulate that. Again, same thing. Okay. Also, increase in estrogen also increases TBG, which also increase total T3 and T4. Okay. So prenatal and diagnostic testing. The goal of prenatal care is to prevent, diagnose, and treat conditions that can lead to adverse fetal and maternal outcome in pregnancy. Expected weight gain, nutrition, and exercise recommendations are outlined in this table. Maternal failure to gain appropriate weight is associated with fetal growth restriction, whereas excess weight gain is associated with diabetes. So recommendation for standard prenatal care, category and recommendation. So in weight gain, guideline for weight gain according to pre-pregnancy body mass index is underweight, BMI less than 18.5, about 12 to 18 kilograms, okay, uh, for weight gain. Acceptable, okay, so 18.5 to 24.9, that is around 11 to 16 kilograms. In overweight, 25 BMI to 29, around 7 to 11 kilogram. Okay, and in obese, BMI more than 30, around 5 to 9 kilograms. So how are we going to remember this? From obese, let me think of this. All right, so it took me a few minutes, but I memorized it. So obese is 5 letters, so 5 kg to 9 kg. Overweight is around 10 letters, so 11. Remember that from that. And then 11 goes on to acceptable range as well. So 11 to 16. And then you add 2 for 18 and 1 for 12. So 12 to 18 for underweight. Okay. And 18 also reflects the BMI, so less than 18.5. Okay. kg. Nutrition. Guidelines for nutritional supplementation. An additional 100 to 300 kilocalories per day. Additional 500 kilocalories per day during breastfeeding. Folic acid calorie supplements 400 mcg daily or 4000 mcg if previous neural tube defect or maternal use of valproate or carbamazepine. Folic supplementation decreases neural tube defects for all reproductive age women. Iron, calcium, and additional guidelines for vegans and others limiting meat and dairy intake are vitamin D and B12. Okay. Exercise 30 minutes of moderate exercise daily while avoiding contact sports. Okay. Harmful substances. Avoid fish with high mercury levels. Moderate caffeine intake. Avoid uncooked meat, fish, eggs. Avoid unpasteurized dairy. Listeria. Group B, streptococcus testing and treatment. Screening for Group B streptococcus or GBS, rectovaginal swab at 36 to 38 weeks. Indications for intrapartum prophylaxis. Okay. Um, uh, Intrapartum prophylaxis. So GBS positive rectovaginal swab at 36 to 38 weeks. GBS bacteria or that's urinary sorry excuse me urinary tract infection anytime during pregnancy. Prior infant with early onset GBS sepsis, unknown GBS status with any of the following: labor at less than 37 weeks, intrapartum fever, rupture of membrane more than 18 hours. Okay, it has been more than 18 hours. I need to write. Okay. Um, okay, so we give prophylaxis for all of these things then. Okay, so GBS positive, UTI or bacteria, and unknown GBS status with any of the following. So labor at less than 37 weeks, intrapartum fever, or rupture at a rupture of membrane more than and has been more than 18 hours. Intrapartum prophylaxis, intravenous IV penicillin. Uh, if you have seen the sketchy one, it's the one where they have like the cap thing. They're explaining the mechanism of action and all that with a little baby astronaut that has like a astronaut uh, helmet. That's cute. Intravenous IV penicillin, regardless of mode of pregnancy. Uh, First generation cephalosporins for patients with low risk penicillin allergy. Clindamycin or vancomycin for high risk of anaphylaxis. Okay. Prenatal diagnostic testing. This table outlines a typical prenatal diagnostic testing schedule by week. The sections that follow describe each recommended screening modality. Okay, all right. So we're on this, I believe. Prenatal visit and diagnostic testing schedule. Uh, Prenatal diagnostic testing and prenatal visits. So week 0 to 28, prenatal visit needs to be every 4 weeks. From week 29 to 35, every 2 weeks, and week 36 to birth every week. Initial visit, heme, complete blood cell count, CBC. So you're gonna do CBC, okay. So type and screen, important for determining RH status. Infectious disease, urine analysis and culture, rubella antibody titer, hepatitis B surface antigen, HBsAg, hepatitis C antigen, rapid plasma reagent, RPR, venereal disease research lab, VDRL, cervical gonorrhea and chlamydia, purified protein derivative, PPD, HIV, tuberculosis testing, or myobacterial tuberculosis, pap smear, okay, to check for dysplasia, consideration of hepatitis C vaccine and varicella vaccine based on history, okay, and if indicated, then HbA1c and sickle cell screening, Discussion of genetic screening, Tay-Sachs disease, cystic fibrosis, and spinal muscular atrophy. Okay, so we're doing UA, RER. Okay, give it a look over. And that, okay. So that's the initial visit. Then weeks 10 to 2 weeks, aneuploidy screening. So multiple options are possible. Cell-free DNA screening, most sensitive and specific screening tool available for trisomy 13, 18, and 21. It is accepted as a primary screening option. Then full integrated test. This is serum pregnancy associated plasma protein A, collected 11 to 14 weeks, crown rump length, measured 10 to 14 weeks, plus quadruple screen in second trimester, HCG, inhibin A, alpha fetoprotein, unconjugated estriol. Combined test, beta HCG, PAPPA, measure of knuckle translucency 10 to 14 weeks. Okay, so we do aneuploidy screening. Okay, transfer that. Okay, so we did that there. 18 to 20 weeks, ultrasonography for full anatomic screen. 24 to 28 weeks, so 1 hour 50-gram glucose challenge test for gestational diabetes screen. If positive, then 3-hour 100-gram uh, glucose challenge test. That's 24 to 28 weeks. Okay. 28 to 30 weeks, RHD antigen, immune globulin for Rh negative women after antibody screen. 35 to 37 weeks, GBS culture, repeat CBC, and 34 to 40 weeks in high risk patients, cervical, chlamydia, and gonorrhea culture, HIV, and RPR. Okay, so 24 to 28. 18 to 20, we do ultrasonography for full anatomic screen. 24 to 28, glucose challenge. 28 to 30, immunoglobulin. Okay. So we give NTD basically for Rh negative women. Okay, so we give that at 28 to 30 weeks. At 35 to 37, GBS culture, repeat CBC. 34 to 40, we do the other tests. Okay. Quadruple screening for fetal aneuploidy. Okay, so this is the one with non-RBC one, right? Complete CBC, type screen. Sorry, not that, this. Okay, so cell-free. There you go. Cell-free DNA, that's the one we do. So, I guess. Okay, so quadruple. So, MSAF, alpha fetoprotein, estriol, inhibin A, and beta HCG. Okay, so the way you remember this is if you put this one, beta right here, okay, so you just ignore this. Ignore this line over there. So it goes A, B, E, I, right? So then if you're doing trisomy 21 Down syndrome, it goes down, up, down, up. Okay, so that's how that goes. A for alpha fetoprotein, B for beta ACG, E for estriol, and I for that. So down, up, up. Okay, whereas in trisomy 18, it's all decreased. Okay, that helps. Okay. Quadruple, you gotta remember that it starts with down. So AFP down. So if you mess that first one up, then it's gonna mess up all of them. So remember which one it is. Okay. So quadruple screening. Quadruple screening consists of 4 elements: maternal serum alpha fetoprotein, inhibin A, estriol, and beta HCG. Uh, Maternal serum alpha fetoprotein produced by the fetus and enters the maternal circulation. Results are reported as multiples of median, sorry, so moms. Measurement results, that's cute. Measurements results depend on accurate gestational dating, multiple gestations, and uterine leiomyomata, that's fibroids, may cause size and date discrepancy. Okay. Remember there was a question on about this in UWorld based on the dating of gestational age or something like that. Anyways, moving on. MSAFP is rarely tested alone, as quad screening has increased sensitivity for detecting chromosomal abnormalities. Okay, so we do all 4 instead of just AFP because it increases sensitivity for detecting chromosomal abnormalities. Okay, so this one, multiple gestation. Increase in maternal serum alpha fetoprotein more than 2.5 moms is associated with the following. So open neural tube defect, abnormal wall defect, okay, so gastroschisis, omphalocele, uh, entity like encephalopathy, anencephaly, and spina bifida, multiple gestation, uh, incorrect gestational dating, fetal death, placental abnormalities, for example, placental abruption. Decrease in maternal serum alpha fetoprotein less than 0.5 is associated with the following: trisomy 21 and 18, and incorrect gestational dating. Okay, so key fact here, still under age at 18. So trisomy 18, it's reduced AFP, decrease estriol, decrease in beta HCG, and inhibin A as well. Key fact, 2 up, 2 down. Trisomy 21, AFP is decreased, estriol is decreased, beta HCG is increased, and inhibin is increased. Okay. Knuckle translucency recommended at age at week 9 to 14. PAPPA. Every time I say that, it reminds me of I got a pen, I got an apple. Pen, apple. Um, Anyways, knuckle translucency. I hope you know what that meme is, because if you don't, then that was really awkward. I got a pen, I got a pineapple. Uh, pineapple. I got a pen, I got an apple, I got a pineapple. Uh, pineapple, apple, pen. Okay, now it's in my head. Anyways, PAPPA, knuckle translucency. Free beta HCG can detect approximately 91% of cases of Down syndrome and approximately 95% of cases of trisomy 18. Advantages: available earlier than CVS. Why not just use Walgreens then? Um, Available earlier than chorionic villus sampling and less invasive than CVS. Okay. Um, CVS is the pharmacy here. That was a joke. I realize it doesn't go well for people out of US. But yeah, see the following section on CVS. Chorionic villus sampling. Okay, table this outlines the relative advantages and disadvantages of CVS, cell-free fetal DNA, and amino synthesis. Okay, so this, okay, let's look at this first. So chorionic villus sampling. So we have catheter, it goes in, goes to the this part. So there's the fetus, placenta, there's the chorionic villi, uterus, ultrasound transducer, transducer. Okay, catheter taking tissue samples from there. Okay, so placental sample, and that's what it is. So variable, cell-free fetal DNA, um, chorionic villus sampling, and immunosynthesis. So when do we do cell-free fetal DNA? We do it in 10 up to 10 weeks. Okay, right. Check. Initial visit. Okay. So yeah, around 10 to 22 weeks. Okay. So 10 weeks procedure, isolation of fetal DNA from blood sample obtained from pregnant patient. Advantages, non-invasive. Okay. Disadvantages may be limited because of low concentration of fetal DNA in maternal circulation. Chorionic villus sampling, 10 to 12 weeks. Procedure, transcervical or transabdominal aspiration of placental tissue. Advantages, genetically diagnostic, available at an earlier gestational age than amniocentesis, sorry. I kept saying amino, I'm sorry. So amniocentesis. Disadvantages, risk for fetal loss relatively high, 1%. Cannot detect open neural tube defects and limb defects associated with CVS at less than 9 weeks. You gotta be sure that's more than 10. Amniocentesis, 15 to 20 weeks. Transabdominal aspiration of amniotic fluid um, using an ultrasound guided needle. Advantages, genetically diagnostic, and disadvantages, premature rupture of membranes, PRM, chorioamnionitis, fetal maternal hemorrhage. Okay, so these are the disadvantages. Okay, so 15 to 20 is when we do amniocentesis. 10, 10, okay. Amniocentesis indicated for the following: concerns for fetal genetic disease based on abnormal aneuploidy screening and or ultrasound finding, RH sensitized pregnancy to obtain fetal blood type or to detect fetal hemolysis, um, evaluation of fetal lung maturity, lecithin to sphingomyelin ratio 2.5 or more, or presence of phosphatidylglycerol performed during the third trimester indicates lung maturity. Okay, so lung maturity, how do you do it? Lecithin to sphingomyelin ratio, it has to be 2.5 or more, or there should be presence of phosphatidylglycerol um, performed during the third trimester indicates lung maturity. Okay, assess for intraamniotic infection with gram stain and culture. Tetralogy. Major defects are apparent in about 3% of births and in roughly 4.5% of children by 5 years of age. This table outlines common teratogenic agents. Okay, so common teratogenic agents and their associated defects, drugs and chemicals defects. Angiotensin converting enzymes, ACE inhibitors. Okay, their defect is because we use it for hypertension and it constricts um, the renal artery, right? Angiotensin constricts efferent Okay, so efferent. Artery defect is fetal renal tubular dysplasia and neonatal renal failure. Okay, so kind of easy to remember that one. Uh, oligohydramnios, FGR. Okay, so that's fetal growth retardation and lack of cranial ossification. Alcohol. Okay, fetal alcohol syndrome, growth restriction before and after birth, intellectual disability, midfacial hypoplasia, smooth philtrum, renal and cardiac defects. Consumption of more than 6 drinks per day is associated with a 40% risk for fetal alcohol syndrome. Amphetamines, preterm delivery, placental abruption, preeclampsia, fetal growth retardation, and fetal demise. Okay, amphetamines. So preterm delivery, placental abruption, preeclampsia, FGR, and fetal demise. Okay. Androgens, that's virilization of female fetuses, uh, advanced genital development in male fetuses, uh, most commonly caused by maternal luteomas. Luteomas, okay. Carbamazepine, that's neurotube defects, fingernail hypoplasia, microcephaly, uh, developmental delay, and FGR. Cocaine, uh, bowel atrasias. I'm I'm suppressing my urges here with cocaine. Bowel atrasias, congenital. Also, there's new urge to say cocaina instead of cocaine. Anyways, bowel atrasias, congenital malformations of the heart, limbs, face, and genitourinary tract, microcephaly, FGR, and cerebral infractions. Okay, so I think the important one here would be the bowel atresia for cocaine. Okay, DES or diethyl stilbestrol. Um, this is the one that they used to give before, but not anymore. It's kind of banned, I think. Clear cell adenocarcinoma of the vagina or cervix, vaginal adenosis, abnormalities of the cervix and uterus or testes, possible infertility. Lead, it increases SAB rate, sudden still or sudden. What's SAB? Oh, they didn't give us one. Okay. SAB rate, stillbirth. Lithium, congenital heart disease, Epstein anomaly. Methotrexate, increase in SAB rate. Okay, again. Um, let me look up what SAB is. Give me a sec. Alright, so SAB is spontaneous abortion. Okay, so it increases spontaneous abortion rate. Methotrexate and lead. Organic mercury, that's known to cause cerebral atrophy, microcephaly, intellectual disability, spasticity, seizures, and blindness. Phenytoin, fetal growth retardation, intellectual disability, microcephaly, dysmorphic craniofacial features, cardiac defects, fingernail hypoplasia. Okay. Radiation, microcephaly, intellectual disability, medical diagnostic radiation delivery less than 50 mgy, microgeiger, I guess. To the fetus, no teratogenic risk. Okay. Um, Streptomycin and kanamycin, hearing loss, cranial nerve, uh, 8 damage. Okay. Tetracycline, uh, permanent yellow-brown discoloration of deciduous teeth, hypoplasia of tooth enamel. Uh, Effects are rare with doxycycline, generally considered safe to use in pregnancy. Rare with doxycycline. Okay, so we give doxycycline instead of this. Okay. Thalidomide, bilateral limb deficiency, anoxia and microtia, and cardiac and GI anomalies. Okay, and I'm gonna look up what those things are. Give me a sec. Okay, so it's anoxia is when the external ear is missing, and microtia is when it's small or not formed properly. Okay. Trimethadione and paramethadione, cleft lip and cleft palate, cardiac defects, microcephaly, intellectual disability. Valproic acid, neural tube defect, spina bifida, microcraniopharyngeal defects. Okay. And vitamin A and derivatives, increase in spontaneous abortion rate, microtia, um, thymic agenesis, cardiovascular defects, craniofacial dysmorphism, microphthalmia, cleft lip or cleft palate, intellectual disability. Warfarin wages war on the fetus. So nasal hypoplasia and stipple bone epiphysis, developmental delay, fetal growth restriction, and ophthalmologic abnormalities. Okay. Congenital infections. Okay, so can occur at any time during pregnancy, labor, or delivery. Common sequelae include the following abnormalities: premature delivery, CNS abnormalities, anemia, jaundice, hepatosplenomegaly, growth restriction. The most common pathogens involved in congenital infections can be remembered through use of torches mnemonic. Okay, so torches, toxoplasmosis, rubella, cytomegalovirus, HIV, herpes virus, herpes simplex virus, varicella zoster virus, and syphilis. Key fact here is pregnant patients should not change a cat's litter box to prevent exposure to toxoplasmosis. Okay. Diagnosis and common congenital infections, disease transmission symptoms, diagnosis, treatment, and prevention. For toxoplasmosis, transmission is transplacental, primary infection via consumption of raw meat or contact with cat feces. Symptoms: hydrocephalus, intracranial calcification, chorioretinitis. Diagnosis: serologic testing, ring enhancing lesions on MRI. Treatment: pyrimethamine, sulfadiazine. Prevention: avoiding exposure to cat feces or uncooked meat during pregnancy. Rubella, transplacental in the first trimester. Okay. Symptoms: purpuric blueberry muffin rash, cataract. Okay. Uh, the mnemonic for this one was "I love ruby earring." Right. So blueberry muffin rash, cataract, intellectual disability, um, hearing loss, and patent ductus arteriosus. Okay. So the love was for heart. It was drawn as heart, and then heart is for the PDA. Earrings was for hearing loss. I in I love or I heart uh, rub, ruby earring was for cataract. Okay. Uh, Diagnosis: serologic testing. Treatment: symptomatic. Prevention: immunization before pregnancy, vaccination of the mother after delivery if serologic titers remain negative. CMV, primarily transplacental. Petechial rash here. Periventricular calcification, that's the important one as well. That's like one of the classic presentation for this. Um, Urine culture, polymerase chain reaction of amniotic fluid. Okay, treatment here is postpartum ganciclovir, and there's no prevention, not applicable. Okay. Then you have herpes simplex virus. So transmission is intrapartum transmission if the mother has active lesion. Transplacental transmissions are rare. Okay. So transplacental for toxo, rubella, and CMV. Okay. Then we have symptoms: skin, eye, and mouth infections, life-threatening CNS systemic infection. Then you have serologic testing for this diagnosis, and treatment is acyclovir at 36 weeks until delivery. Okay. And prevention is C-section if lesions are present at delivery. HIV, in utero at delivery or via breast milk. Okay. So that's how the transmission occurs: in utero, at delivery, or via breast milk. Often, we're doing symptoms, often asymptomatic, failure to thrive, bacterial infections, increased incidence of upper and lower respiratory disease. Okay. Diagnosis: enzyme-linked immunosorbent assay, ELISA, and Western blot. And then treatment: highly active antiretroviral therapy, HART. And then we have prevention, that's azidothymide or AZT, or nevirapine in pregnant women with HIV. Elective C-section if viral load is more than 1,000. Treatment of infants with prophylactic AZT. Avoidance of breastfeeding. Okay. When diagnosis and treatment of common congenital infections, disease, syphilis, transmission, symptoms, diagnosis, treatment, prevention. Okay, so syphilis, transmission is intrapartum, transplacental transmission is possible. Symptoms: maculopapular rash, skin rash, lymphadenopathy, hepatomegaly, snuffles, mucopurulent rhinitis, osteitis, late congenital syphilis, Sabershins, Seleno's, CNS involvement, Hutchinson's triad, uh, peg-shaped central incisors, deafness, interstitial keratitis. Diagnosis: dark field microscopy, VDRL, RPR, fluorescent treponemal antibody absorption. Treatment: penicillin if allergic. Should desensitize and give penicillin if they're allergic. Prevention: penicillin in pregnant patients who test positive. Zika virus, transplacental transmission, microcephaly, craniofacial disproportion, neurologic and ocular abnormalities, and Zika diagnosis: Zika RNA detection. Okay, there's no treatment, and prevention is avoidance of topical tropical mosquito infested regions. Okay, on to abortion. Spontaneous abortion: this loss of gestation before 20 weeks gestation. More than 80% of cases occur in the first trimester. Associations are as follows: maternal factor, inherited thrombophilia, factor V Leiden, prothrombin, antithrombin, protein C and S deficiencies, methylene tetrahydrofolate reductase deficiency, hyperhomochromis, homocystinemia, okay, hyperhomocystinemia, okay, so inherited thrombophilia, basically, okay, all the hypercoagulability causes, basically, immunologic issues, antiphosphatidyle antibodies, sorry, this reminds me of that. It's a dark humor thing, but it reminds me of that show where there are a bunch of contestants, and one of them was telling her story how she had an abortion, and the host, everyone was like, "Oh my God, really?" Oh, and then she's like, "Yeah," and it was, and they were twins, and someone from the back is like, "Oh, dumb homicide." That double homicide was hilarious. With the whole show's ambience, it was like so sad, and they had violins going in the background. Someone just yells, "Oh damn!" Double homicide. So yeah. Okay, back to this. Immunologic issues, antiphospholipid antibodies, alloimmune factors, anatomic issues, uterine or cervical abnormalities, cervical insufficiency, cervical conization, or loop electrosurgical excision procedure, LEEP, cervical injury, and diethyl or DES exposure, basically. Endocrinology issues, DM, hypothyroidism, uh, progesterone deficiency, genetics, osteogenesis imperfecta type 2. This is severe and lethal. Infants present with multiple fractures and die in utero or shortly after birth. Other maternal trauma, increase in maternal age, infection, dietary deficiencies. Environmental factors, tobacco, alcohol, excessive caffeine, more than 500 milligram per day, toxins, drugs, radiation. Fetal factors, anatomic malformation, chromosomal abnormalities, a factor in approximately 50% of spontaneous abortions in the first trimester, 20% to 30% in second trimester losses, and 5% to 10% in third trimester losses. Recurrent SAB, spontaneous abortion, two or more consecutive SABs or three SABs in 1 year. Causes dependent on timing. Uh, Determining possible causes requires karyotyping of both parents, workup of mother for hypercoagulability, and evaluation of uterine anatomy. Okay. Early, less than 12 weeks, chromosomal abnormalities likely cause. If it's late, 12 to 20 weeks, uh, hypercoagulable states, for example, antiphospholipid syndrome, SLE, factor V proteinase deficiency, and cervical insufficiency. If antiphospholipid antibodies are detected, false positive venereal disease, VDRL, and falsely uh, prolonged partial thromboplastin time may be seen. Low molecular weight heparin and low dose aspirin provide prophylaxis against recurrent SAB. Okay, so may be seen, and low molecular weight heparin and low dose aspirin provide prophylaxis against recurrent SAB. Okay. History and physical examination. SAB can be categorized by visual examination of the cervical OS, open versus closed, and the presence of status of the fetus and products of conception. Okay, so this table for types of SAB, types of spontaneous abortion, type, symptoms, diagnosis, and treatment. Complete type, That is, signs and symptoms are cessation of bleeding and cramping, expulsion of products of conception. Okay, POC. Diagnosis closed OS, ultrasonography showing no POC. Um, Product of conception. Okay. Treatment is none. Threatened. Okay. Signs and symptoms for threatened spontaneous abortion is uterine bleeding with or without abdominal pain, often painless, on no product of conception expulsion. Closed ostium OS plus intact membrane plus fetal cardiac motion on ultrasonography. Treatment here is follow-up ultrasonography to assess viability of the fetus. Okay, another type is incomplete. Signs and symptoms: partial product of conception, expulsion, bleeding or mild cramping. Okay, diagnosis here is visible tissue on examination, open OS POC, present on ultrasonography treatment. Treatment here: manual uterine aspiration, MUA, if less than 12 weeks, or dilation and curettage, DNC. May also use misoprostol or expectant management in inevitable uh, and missed SAB. Visible tissue on examination. Okay, sinus symptoms here are open ostium, and diagnosis are uh, products of conception present on ultrasonography. Inevitable sinus symptoms: uterine bleeding and cramps, no POC expulsion. Diagnosis: open OS with or without rupture of membranes. POC present on ultrasonography. Missed: asymptomatic with or without cramping, no bleeding. Diagnosis: closed OS, no fetal cardiac activity, POC present on ultrasonography. Septic: this is foul smelling discharge, abdominal pain, fever, and cervical motion and tenderness with or without POC expulsion. Maternal mortality 10% to 15%. Okay, hypertension, hypothermia, increased WBC count, and blood culture. And treatment here is manual uterine aspiration or DNC and IV antibiotics. Stillbirth: absence of fetal cardiac activity more than 20 weeks. Diagnosis: uterus small for gestational age, no fetal heart tones or movement on ultrasonography. Uh, Treatment: if less than 24 weeks, dilatation and evacuation, DNE. Okay, if less than 24 weeks. Okay, if more than 24 weeks, induction of labor within 1 to 2 weeks, based on patient preference. Offer autopsy to attempt to determine cause of death. Okay. Elective abortion. Okay, so trimester, procedure, and gestational age. Okay, so the first trimester, 90% of abortions happen here. Procedure, medical management, oral mifepristone, low dose, plus oral vaginal misoprostol. Okay, now surgical management here is manual uterine aspiration and dilation and curettage with vacuum aspiration. Okay, so if it's less than 10 weeks, then you will do oral mifepristone and misoprostol. If it's more than 10 weeks, then manual uterine aspiration and DNC with vacuum aspiration. Second, 10% of abortions. Okay. Uh, Obstetric management, induction of labor, typically with prostaglandin, amniotomy, and oxytocin. And this is gestational age 13 to 24 weeks, depending on the state laws. Okay, typically with prostaglandin, amniotomy, and oxytocin. Yes. Surgical management, dilation and evacuation, D&E, same as above for gestational age. Okay. So 13 to 24 weeks, depending on which state you're in. Okay, and that's for more than 10 weeks and less than 10 weeks is the okay. And we were doing abortion. Okay, so abortion diagnosis. Diagnosis by clinical presentation and physical examination, non-viable pregnancy, gestational sac more than 25 mm without a fetal pole, or absence of fetal cardiac activity with when CRL more than 7 mm on transvaginal ultrasonography. Best initial test. Ultrasonography can identify the following: gestational sac 5 to 6 weeks from LMP, fetal pole at 6 weeks, fetal cardiac activity at 6 to 7 weeks. Next best test is serum beta HCG. Treatment here is see this table for treatment specific to the type of SAB. Administer Rh immunoglobulin if the mother is Rh negative. Okay. Uh, Key fact: if fever, vomiting, purulent discharge, and/or hemodynamic instability are seen after a spontaneous or elective abortion, septic abortion should be suspected. This is a medical emergency that requires broad-spectrum antibiotics and immediate surgery to remove infected tissue. Okay. Elective termination of pregnancy. It has been estimated that 50% of all pregnancies in the United States are unintended. Okay. Wow, 50% of all pregnancies in United States are unintended. Okay, so 50% of people born in America are accidents, is what they're saying. About 25% of all pregnancies end in elective abortions. Okay. Options for elective abortion depend on gestational age and patient preference. See that table. Complications of abortion: septic abortion, retained products of conception, disseminated intravascular coagulation (DSE), okay, and can lead to that, and endometrium metritis, okay. Mnemonic: the eyes are open. Finding in cervical exam during SCV, inevitable and incomplete show open EOS. Okay. Incomplete. Okay. So open OS and inevitable is OS. So it's open. Okay. QQQ. Need to figure out how to differentiate between these, but I'm sure you will tell us how to do that. So moving on. Maternal complications of pregnancy: hyperemesis gravidarum, persistent vomiting not related to other causes leading to starvation, ketosis, and weight loss, usually at least a 5% decrease from pre-pregnancy weight. More common in first pregnancies, multiple gestations, and molar pregnancies. Increase in beta HCG and uh, increase in estradiol have been implicated in pathophysiology. Okay. Key fact here: rule out trophoblastic disease with ultrasonography in a pregnant patient who presents with severe nausea and vomiting. History and physical examination distinguish from nausea and vomiting of pregnancy (NVP) by severity, presence of weight loss and ketosis, and timing. Acid reflux, gastroenteritis, hyperthyroidism, and neurologic conditions can also cause NVP and should be on the differential diagnosis. So again, which ones do it? Acid reflux, gastroenteritis, hyperthyroidism, and neurologic conditions. They can cause nausea and vomiting of pregnancy. Okay. Diagnosis, clinical diagnosis. Best initial test is ultrasonography, evaluation for trophoblastic disease or multiple gestation, evaluation for electrolyte abnormalities, for example, hypokalemia, abnormal liver, enzymes, amylase, and lipase. Wernicke encephalopathy from vitamin B1 deficiency possible in severe cases. The physician can look for gait ataxia and oculomotor dysfunction. Treatment. Best initial treatment. Sorry, water break. Treatment. Best initial treatment. Hold on, where was I? I think I was there. So Wernicke uh, encephalopathy from vitamin B1 deficiency possible in severe cases. The physician can look for gait ataxia and oculomotor dysfunction. Okay. Treatment. Best initial treatment. Dietary changes and deoxylamine pyridoxine. Okay. If no response, discontinue deoxylamine pyridoxine and use metoclopramide, promethazine, or prochlorperazine. Consider ondansetron if vomiting is not resolved with treatments mentioned earlier. Okay. Um, all right. I was just trying to think of mnemonic to remember these. Okay. Uh, but basically, you're going with pyridoxine 1, promethazine, and prochlorperazine. They all start with P, and you give P's for puke. That's the best I can do in sleep deprived state. If dehydrated, administration of IV fluids, IV nutritional supplementation, and ondansetron IV. Okay. Diabetes. Diabetes is pregnancy is in pregnancy is divided into the following two categories: pregestational DM and gestational DM. Pregestational DM, that's onset before pregnancy, type 1 or type 2 DM. Gestational DM is onset during pregnancy. Consider early screening, fasting glucose, first trimester HbA1c, or early glucose tolerance test for the following risk factors: overweight or obese, BMI more than 25, physical inactivity, first degree relative with DM, have previously given birth to an infant weighing 4,000 grams, approximately 9 pounds or more, previous gestational DM, women with polycystic ovarian syndrome, HbA1c of more than 5.7%, impaired glucose tolerance or impaired fasting glucose on previous testing, history of cardiovascular disease, other clinical conditions associated with insulin resistance, for example, metabolic syndrome and acanthosis nigricans. Pregestational diabetes. Okay. Here the key fact first. It's greater than 8. Greater than 8, investigate. If HbA1c is more than 8%, look for congenital abnormalities. Pre-gestational diabetes, observed in 1% of all pregnancies. Insulin requirements may increase as much as threefolds. Poorly controlled DM is associated with an increased risk for congenital malformations, fetal loss, and maternal fetal morbidity during labor and delivery. Testing and treatment for mother: renal, ophthalmic, and cardiac evaluation to assess for end organ damage. Best initial treatment: lifestyle modification with diet and exercise, addition of insulin therapy if poor response. Strict glucose control is important to minimize fetal defects. Fasting morning of 95 mg per dl less than or more than, sorry, 95 mg or less. Okay. And 2 hour postprandial is less than 120. Okay. Delivery and postpartum. Maintain normal glycemia 80 to 100 during labor with an IV insulin drip and hourly glucose measurements. Okay. Consider delivery in the setting of poor maternal glucose control, preeclampsia, macrosomia, or evidence of fetal lung maturity, preferably after 32 weeks. Consider C-section in the setting of an estimated fetal weight of uh, 4,500 grams or more than that. Okay. Fetus, 16 to 24 weeks. Ultrasonography to determine fetal anatomy. Okay, so 18 to 20 weeks. 32 to 34 weeks. Antepartum fetal surveillance. Uh, for example, non-stress test, contraction stress test, biophysical profile, if poor glucose control or small vessel disease. Hospitalization, if maternal DM has been poorly controlled or fetal parameters are a concern, serial ultrasonography for fetal growth. Okay. um, Key fact here: hyperglycemia is in the first trimester suggests pre-existing DM and should be managed as pre-gestational DM. Okay. Complication: pre-gestational DM is a risk factor for a variety of antepartum, intrapartum, and postpartum maternal and fetal complications. This table. Tight glycemic control is the best way to prevent these complications. Gestational diabetes. Carbohydrate intolerance for variable severity, first diagnosed during pregnancy, occur in 3% to 5% of all pregnancies and is usually diagnosed in the second trimester, 24 to 28 weeks. Okay. Um, Complications of gestational diabetes mellitus. Okay. Uh, Maternal complications are diabetic ketoacidosis or hyperglycemic hyperosmolar non-ketotic coma for type 2, preeclampsia, eclampsia, cephalopelvic disproportion for macrosomia and need for C-section, preterm labor, infection, polyhydramnios, postpartum hemorrhage, maternal mortality. Fetal complication, small left colon syndrome, macrosomia or FGR, cardiac and renal defects, neurotube defects for sacral agenesis, hypocalcemia, polycythemia, hyperbilirubinemia, uh, hypoglycemia from hyperinsulinemia, respiratory distress syndrome, birth injury, for example, shoulder dystocia, and perinatal mortality. Okay. History and physical examination. Typically asymptomatic, may present with edema and polyhydramnios or a large for gestational age infant. More than 90%. Okay. And diagnosis: best initial test, routine screening with a 1 hour 50-gram glucose challenge test, venous plasma glucose measured 1 hour later, performed at 24 to 28 weeks. Value of 140 or more considered abnormal. Confirmation with an oral 3 hour 100-gram glucose tolerance test. Next, if positive screening test showing any two of the following: fasting more than 95, 1 hour more than 180, 2 hours more than 155, and 3 hours more than 140. Okay. So you give 1 hour 50 grams, okay, and then you measure 1 hour later, performed at 24 to 28 weeks, and value of 140 or more is considered abnormal. How do you confirm it? You give 100 gram in that after that, and then you wait for 3 hours and then check, and if it's still more than 140, then it's also considered abnormal. But normally you'll check at 1 hour, right? So it's going to be more than 180 in that case. Okay. Treatment here is in mother. Best initial treatment. American Diabetes Association diet, regular exercise and strict glucose monitoring 4 times per day. Insulin is the gold standard. If dietary control is insufficient, tight maternal glucose control, fasting of 95 or less. Okay, now 1 hour postprandial prandial is 140 or more. 2 hours postprandial is 120 or more. Improves or outcome. Intrapartum insulin and dextrose to maintain tight control during delivery. Okay. Fetus, periodic ultrasonography and anesthesia to uh, assess fetal growth and well-being. Recommended induction of labor at 39 to 40 weeks in patients with gestational diabetes controlled on uh, insulin. Complications. More than 50% of patients with gestational diabetes develop glucose intolerance and or type 2 diabetes mellitus later in life. Okay. At 6 to 12 weeks postpartum, the physicians should screen for DM, 75 gram, 2 hours GTT, and repeat testing every 3 years if normal results. Key fact: keys to management of gestational diabetes: 1. ADA diet, that's American Diabetes Association diet. Okay. 2. Insulin if needed. 3. Ultrasonography for fetal growth, and 4. Antepartum surveillance if requiring insulin and or oral hypoglycemic agent. Hypertensive disease in pregnancy. Chronic and gestational hypertension defined as below as follows. Chronic hypertension and gestational hypertension. Chronic hypertension uh, presents before conception or at less than 20 weeks. Okay. Can be diagnosed postpartum if increased blood pressure persists for more than 12 weeks postpartum. Possibility for up to 1/3 of patients with chronic hypertension to develop superimposed preeclampsia. Gestational hypertension, idiopathic hypertension, systolic BP is more than 140 or diastolic is 90 or more, measured twice, um, more than 4 hours apart. Without significant proteinuria, less than 300 milligram per liter, develops at 20 or more weeks. Okay, 20 weeks or more. Okay, so that's 20 weeks, and this was less than 20. So for it to be chronic, present before 20 weeks, and here for gestational, it has to be more than 20 weeks. Okay. Possibilities for up to 25% of patients with gestational hypertension to develop preeclampsia must normalize within 12 weeks after pregnancy. Okay, so it has to normalize within 12 weeks, and if it's persists more than 12 weeks, then it can be considered uh, chronic. Okay. Treatment, close monitoring of blood pressure, best initial treatment with appropriate antihypertensive, for example, metaldopa, levetolol, nifedipine. If systolic blood pressure is 160 or more, or diastolic is 110 or more, this is um, a hypertensive crisis that calls for levetolol, hydralazine, or nifedipine because of short onset of action. There was a mnemonic for this. I'm trying to remember. Mother's love knew something. So mother's mother was for metaldopa, L love for levetolol, new for nifedipine, and something for hydralazine. Or mothers hug newborn. Oh, mothers love to hug newborn. I don't think that was it, but it works. So mothers love to hug newborn. So metaldopa, levetolol, nifedipine, and hug for hydralazine. Okay, so that works. The patient should not take angiotensin converting enzyme inhibitors or diuretics. Okay, because they're teratogenic. ACE inhibitors are known to lead to uterine ischemia and fetal renal damage defects, and diuretics because it can aggravate low plasma volume to the point of uterine ischemia. Okay, right there. Complications similar to those of preeclampsia. See next. Preeclampsia, new onset hypertension, systolic blood pressure more than 140, or diastolic BP 90 or more, and proteinuria, more than 300 milligram of protein in a 24-hour period, or elevated urine or protein creatine ratio of 0.3 or more, occurring at more than 20 weeks gestation up to 6 weeks post delivery. Okay. Preeclampsia with severe features defined as new onset hypertension with new onset of any of the following features, with or without proteinuria. Okay, so preeclampsia with severe features defined as new onset hypertension with new onset of any of the following features. Platelet count less than 100,000. Serum creatinine more than 1.1 mg per deciliter, or doubling of creatinine concentration in the absence of other renal disease. Liver transaminase as at least twice the upper limit of normal. Pulmonary edema, neurologic or visual symptoms. A new onset headache, unresponsive to medication, and not accounted for by alternative diagnosis. HELP syndrome. So what is HELP syndrome? It's hemolysis, elevated liver function tests, and low platelets. Okay. So again, hemolysis, elevated liver function tests, and low platelets. Okay. So HELP syndrome, a variant of severe preeclampsia with severe features, consists of hemolytic anemia, elevated liver enzymes, and low platelets. Etiology is unknown. Clinical manifestations are explained by vasospasms, uh, leading to distension of hepatic capsule, hemorrhage, and organ necrosis. Risk factor, nulliparity, extremes of age, less than 20 or more than 35, multiple gestation, molar pregnancy, renal disease caused by SLE or type 1 diabetes, A family history of preeclampsia and chronic hypertension. It is indication for delivery. Okay. History and physical examination. See this table for the signs and symptoms of preeclampsia. Treatment: recommended low dose aspirin daily during pregnancy. Delivery of the fetus is the only cure for preeclampsia. Close to term or worsening preeclampsia, induce delivery with IV oxytocin, prostaglandin, or amniotomy. Delivery should occur no later than 37 weeks. Presentation of preeclampsia and eclampsia. Okay, so disease severity, signs and symptoms, and delivery. So for preeclampsia, signs and symptoms are uh, usually asymptomatic. Blood pressure is 140 by 90 or more. mmHg on 2 occasions, more than 4 hours apart, and proteinuria more than 300 milligram per 24 hours, or 2 positive urine sticks. Delivery at 37 weeks. Preeclampsia with severe features. Any one of the following. Blood pressure is more than 160 by 110. On 2 occasions more than 4 hours apart. Cerebral changes, severe headache, somnolence. Visual changes, blurred vision, scotoma. Other, progressive renal insufficiency, pulmonary edema, right upper quadrant pain, hemolysis, elevated liver enzymes, thrombocytopenia, HELLP syndrome. Delivery: hospitalization, blood pressure control, delivery by 34 weeks, must balance maternal risk with risk of prematurity in the infant. Okay, so must balance maternal risk with risk of prematurity in the infant. Okay. Okay, and eclampsia, that's the one with seizures. Most common signs preceding eclamptic attack: headache, visual changes, and right upper quadrant pain, uh, or epigastric pain. Seizures severe if not controlled with anticonvulsant therapy. Delivery is immediate delivery. Okay, so we were reading treatment for preeclampsia, continued. Far from term, more than 34 weeks. Then provide expectant management with cross surveillance, hospital admission for uncontrolled severe range blood pressures. Prevent intrapartum seizures with a continuous magnesium sulfate drip. Continue seizure prophylaxis for 24-hour postpartum. Treat magnesium toxicity with IV calcium gluconate. Preeclampsia with severe features. Control blood pressure with labetalol and or hydralazine. Goal is less to get the blood pressure less than 160 by 110, and control, with a diastolic blood pressure of 90 to 100 to maintain fetal blood flow. Okay. Provide a continuous magnesium sulfate drip and deliver by induction or C-section once term. Okay, so here, far from term, what do we do? Expected management. Uh, Expectant management, okay, with surveillance, and hospital admission for uncontrolled blood pressure. Continuous magnesium sulfate drip, continuous seizure prophylaxis for 24 hours postpartum, and treat magnesium toxicity with IV calcium gluconate. Here, with severe features, here what we do is um, we control blood pressure with labetalol or hydralazine. Okay, and the goal is to get it lower than 160 by 110, and diastolic around 90 to 100. Provide a continuous magnesium sulfate drip, delivered by induction or C-section once term. Complications: prematurity, fetal distress, stillbirth, placental abruption, seizures, DIC, cerebral hemorrhage, serous retinal detachment, and fetal maternal death. Key fact here is watch for signs of magnesium toxicity, loss of deep tendon reflexes. Okay, so these are the things for the look out for if you're giving magnesium sulfate drip, right? So watch for signs of magnesium toxicity, loss of deep tendon reflexes, respiratory paralysis, and coma. Uh, let's do the question first. A 36-year-old Gravida 1 Para 0 woman with a history of SLE at 36 weeks presents with headache and right upper quadrant pain. She is admitted and found to have blood pressure of 165 by 100 and 170 by 105 mmHg, uh, when tested twice 6 hours apart. She has 3 plus protein on urine dipstick. Once her blood pressure has been controlled with labetalol, what are the next steps in management? To provide continuous magnesium drip, right? Magnesium sulfate and C-section or delivery. The patient has preeclampsia with severe features. The next steps in management are to start magnesium sulfate drip for her seizures prophylaxis, for give antihypertensive medications, and deliver by induction of C-section. The physician should check for and organ enrollments with labs, platelet, liver enzymes, and creatinine. Okay. Eclampsia. New onset grand mal seizures in a patient with preeclampsia. History and physical examination. See this table for signs and symptoms of eclampsia. Treatment. Delivery of the fetus is the only cure for eclampsia. Okay. Management of maternal hypertension with labetalol or hydralazine. Seizure control prophylaxis with magnesium if seizures recur. Give IV diazepam. Monitor for clinical magnesium toxicity. There is no need to routinely monitor magnesium blood levels if renal function is normal. Monitor fetal status, um, control blood pressure, limit fluids, use urinary Foley catheter for strict intake and output IOs. Okay, intake and outputs. Okay. Okay, so I'm gonna have to do that again. So if seizure recur, give IV diazepam. Monitor for clinical magnesium toxicity. There is no need to routinely monitor magnesium blood levels if renal function is normal. Monitor fetal status, control blood pressure, limit fluids, use urinary Foley catheter for strict intake and outputs. Initiate emergent delivery once the patient is stable and convulsions are controlled. Postpartum management is the same as that for preeclampsia. Seizures may occur antepartum 25% of the time, intrapartum 50% of the time, or postpartum 25% of the time. Most occur within 48 hours after delivery. Complications, cerebral hemorrhage, aspiration pneumonia, hypoxic encephalopathy, thromboembolic events, and fetal maternal death. Urinary tract infection and asymptomatic bacteriuria. Asymptomatic bacteriuria occurs in up to 7% of pregnant patients, and 30% to 40% will subsequently develop cystitis or pyelonephritis if untreated. Persistent untreated bacteriuria places the patient at a high risk for preterm labor, low birth weight, and prenatal mortality. E. coli is responsible for 70% to 90% of infections. History. Okay, so E. coli. Okay. And 30 to 40% cystitis, pyelonephritis if untreated. Okay. 7% of the pregnant. History and physical examination. Asymptomatic bacteriuria, screening 12 to 16 weeks, positive urine culture on first trimester screen, 10 to the power of 5 or more colony forming units, CFUs, Urinary tract infection, UTIs. Uh, so you'll see dysuria, urinary urgency and frequency, pyelonephritis, same as UTI, fever, and costovertebral angle tenderness. Okay. Diagnosis: best initial test, urine analysis and positive urine culture. Treatment: asymptomatic bacteriuria and UTI 3 to 7 days, nitrofurantoin. Avoid in first trimester if possible. Cephalexin, amoxicillin clavulanate, or fosfomycin. No fluoroquinolones or TMP-SMX in first or third trimester. Do a follow-up culture at 1 week as test of cure. Okay, so 3 to 7 days nitrofurantoin. Avoid in first trimester if possible. Cephalexin, amoxicillin clavulanate. So okay, augmented, right? Or fosfomycin. Okay, we don't give TMP-SMX. That's number one, and no fluoroclones in first and third trimester. Okay. Pyelonephritis. Admittance to hospital. IV fluids. IV third generation cephalosporin. Suppressive antibiotics based on culture susceptibility for remainder of pregnancy, and follow-up culture for test of cure. Um, GBS prophylaxis during time of delivery if GBS UTI at any time during pregnancy. Okay. So for pyelonephritis, admittance to a hospital, IV fluid, third generation, cephalosporin, supportive antibiotic based on culture and sensitivity, and follow-up for test of cure. GBS prophylaxis if uh, during the time of delivery, if GBS UTI at time during pregnancy. Okay. Intrahepatic cholestasis symptoms: maternal pruritus, mainly on palms and soles, can also present with right upper quadrant pain, sleep deprivation, and steatorrhea. Labs: raised serum bile acids, most sensitive, increased aminotransferases, alkaline phosphatase, and total direct bilirubin, which is less specific. Okay, so the most specific one is raised serum bile acids. Risk: stillbirth, um, preterm delivery, and meconium-stained amniotic fluid. Management: urosdeoxycholic acid and consideration of delivery at 36 weeks. Okay. Active fatty liver in pregnancy, acute fatty liver in pregnancy. Rare, life-threatening complication in the third trimester of pregnancy. Symptoms are nausea, vomiting, right upper quadrant epigastric pain, fulminant liver failure, scleral icterus. Labs: aminotransferases 2 times normal. Okay. Increased bilirubin, thrombocytopenia, DSC, acute kidney injury, profound hypoglycemia. Management is immediate delivery due to high fetal and maternal mortality. Okay, we don't have the images here, so what it is was normal intrauterine pregnancy and ectopic pregnancy. Transvaginal ultrasonograms showing a normal intrauterine pregnancy with a gestational sac containing a yolk sac within the uterine cavity and a complex mass. Ectopic pregnancy adjacent to an empty uterus. Okay. So obstetric complications of pregnancy: ectopic pregnancy, most often tubal, 95%, but can be abdominal, ovarian, or cervical. History and physical examination: presents with unilateral lower abdominal pain and vaginal spotting, bleeding, although some patients are asymptomatic. Associated with etiologies that cause damage to the fallopian tubes, including a history of pelvic inflammatory disease, pelvic surgery, DES use, and endometriosis. Differential diagnosis includes spontaneous abortion, ovarian torsion, pelvic inflammatory disease, and ruptured ovarian cyst. Diagnosis: Evaluate for ectopic pregnancy in all females of reproductive age presenting with abdominal pain and positive pregnancy test. Um, Best initial test, a transvaginal ultrasonogram. Okay, see this figure. So transvaginal ultrasonogram for ectopic pregnancy. Next best step, serial serum beta HCG may be used to stratify hemodynamically stable patients in whom transvaginal US is non-diagnostic. Okay, so less than 3500 serial beta HCG until levels reach 3500 international unit per liter, which is when an intrauterine pregnancy should be seen. Okay. So next best initial is TBUS. Next best step is serum beta ACG to stratify hemodynamically stable patient in whom TBUS is non-diagnostic. And if it's less than 3500, we do serial until it reaches 3500 when we can finally see intrauterine pregnancy. Levels in viable intrauterine pregnancy usually rise 50% to 100% in 48 hours. More than 3500 lead to repeat beta HCG and US in 2 days. Mnemonic. These symptoms pave the way for a diagnosis of ectopic pregnancy, pain, amenorrhea, or vaginal bleeding, ectopic pregnancy. Key fact here is unstable patients are those with signs of peritoneal irritation, for example, rebound tenderness, require emergent surgical intervention regardless of US finding and HCG levels. Treatment for ectopic pregnancy, medical treatment, methotrexate, is sufficient for small unruptured tubal pregnancies. Surgical options include sulpigenectomy and sulpingostomy with evacuation, laparoscopy or laparotomy. Complications, tubal rupture and hemiperitoneum, a surgical emergency. Okay, so for medical, it's methotrexate. Surgical, salpingotomy and salpingostomy with evacuation. And complication is tubal rupture and hemiperitoneum. Okay, onto moles. Complete versus partial moles. Okay, variable, complete, and partial. A mechanism for complete is um, serum fertilization of an empty ovum. Karyotype is going to be 46XX. Okay. Fetal tissue, there are not going to be any fetal tissues. Okay. In partial, um, you will have fetal tissue there. Karyotype for partial is 69 3 chromosomes, XXY. And mechanism here is normal ovum fertilized by 2 sperms. Okay, so 69 chromosomes there, and complete it's 46. Okay, so I got this from the step 1 FA. Uh, it has a more elaborate chart for this. So complete more. Karyotype 46XX, most common 46XY. Components, most commonly enucleated egg plus single sperm, subsequently duplicates paternal DNA. Histology, hydropic villi, circumferential and diffuse trophoblastic proliferation. There are no fetal parts. Staining for P57 protein, negative. Uterine size is increased. HCG is very much increased. Imaging, honeycombed uterus or clusters of grapes. Snowstorm. On ultrasound, risk of invasive mole is 15 to 20%. Risk of choriocarcinoma is 2%. Partial mole, 69XXX, triple X, 69XXY, 69XYY. So The components are 2 sperms and 1 egg. Histology is only small. Some villi are hydropic, focal, minimal trophoblastic proliferation. Okay, whereas this was diffuse. There are fetal parts. Yes, partial equals fetal parts. Staining for P57 protein is positive, maternally expressed. Partial mole is P57 positive. Okay, not applicable for uterine size, and HCG is increased, but not to the amount of complete mole. Imaging, fetal parts are going to be seen there. Risk of invasive mole is less than 5%. Risk of choriocarcinoma is also rare. Okay. Gestational trophoblastic disease, a range of proliferative trophoblastic abnormalities that can be benign or malignant. Benign gestational trophoblastic disease, it includes complete and partial molar pregnancies. Malignant GTD. Molar pregnancies may progress to malignant GTD, invasive, including the following: invasive hydatid form moles 10% to 15%, choriocarcinoma 2% to 5%. Complications of malignant GTD include pulmonary or CNS metastasis and trophoblastic pulmonary emboli. History and physical examination. GTD presents with first trimester uterine bleeding, hyperemesis gravidarum, preeclampsia, eclampsia at less than 24 weeks, and uterine size greater than dates. Risk factors include extremes of age, less than 20 or more than 40 years, and a diet deficient in folate and beta carotene. Diagnosis include initial test is pelvic examination may reveal enlarged ovaries, bilateral theca lutein cysts, and expulsion of grape-like molar clusters into the vagina. Next best, most accurate test, pelvic ultrasonography reveals a snowstorm appearance with no gestational sac or fetus present. See this figure. Lab show markedly increased serum beta HCG, usually more than 1 lakh or 100,000. X-ray of the chest may show lung metastasis, and DNC reveals cluster of grapes tissue. Treatment, best initial treatment is evacuate the uterus with DNC, follow with weekly beta HCG to undetectable or negative weekly, and then monthly for 6 months. Contraception for at least 6 months. Treat malignant disease with chemotherapy, methotrexate, or dectinomycin. Treat residual uterine disease with hysterectomy. Chemotherapy and irradiation are highly effective for metastasis. Molar pregnancy transvaginal ultrasonogram shows a large complex intrauterine mass with cystic regions that have the characteristic appearance of grapes, and also known as snowstorm appearance. Antepartum hemorrhage and abnormal placentation. Any bleeding that occurs after 20 weeks complicates 3% to 5% of pregnancies. Okay. Most common cause, placenta abruption and placenta previa. See this table and this figure and this figure. Okay. So we're doing antepartum hemorrhage and abnormal placentation. So any bleeding that occurs 20 weeks after and complicates 3% to 5% pregnancies. Okay. Placental abruption versus placenta previa, which shows the preview, and vas previa, where you see the vessels. Okay. So variable, placental abruption, previa, and vas previa. Pathophysiology for placental abruption. Premature before delivery, separation of normally implanted placenta. Incidence is 1 in 100. Risk factor is hypertension. Okay, hypertension, abdominal pelvic trauma, tobacco or cocaine use, previous abruption, and rapid compression of an overdistended uterus, excessive stimulation. Okay. Symptoms: painful vaginal bleeding that does not spontaneously cease, abdominal pain, uterine hypertonicity, fetal distress. Diagnosis: okay, so painful vaginal bleeding that does not spontaneously cease, abdominal pain, uterine hypertonicity, fetal distress. Diagnosis: primarily clinical, transabdominal, transvaginal ultrasonography, uh, sensitivity only 50%. The physician should look for a retroplacental clot, most useful for ruling out previa. Management: stabilize patient with mild abruption and premature fetus, manage expectantly, hospitalize, start IV and fetal monitoring, type and cross-match blood. Moderate to severe abruption, immediate delivery is indicated. Vaginal delivery with amniotomy if mother and fetus are stable, and delivery is expected soon. C-section for maternal or fetal distress. Complications: hemorrhagic shock, DIC in 10% of patients, recurrence risk 5% to 15%, fetal hypoxia. Okay. Placenta previa. This is abnormal placental location. Total placenta covers the cervical ostium or OS. Uh, Marginal placenta extends to the margin of the OS. Okay. Lying, low lying placenta is in close proximity of the OS. Okay. So let me get pictures of these. So we have total, which is totally blocking the ostium opening right here, complete previa. Partial would be just a little bit of it uh, is open, right? So right there. Marginal is it's at the margin, it's covering the margin, and low lying is it's about to cover it. Okay. So total placenta covers the cervical ostium. Marginal is extends to the margin of the ostium. Okay. And low lying is in close proximity to the ostium. Incidence is 1 in 100. 1 in 200. Risk factor is prior C-sections, uterine surgeries, grandpa multiparity, advanced maternal age, multiple gestation, prior placental preview. preview. Symptoms: painless, bright red bleeding that often ceases in 1 to 2 hours with or without uterine contractions. Usually no fetal distress. Diagnosis: transabdominal, transvaginal ultrasonography sensitivity is more than 95%. The physician should look for an abnormally positioned placenta. Partial previa can resolve as the lower uterine segment expands with the pregnancy progression. Okay. Management: do not perform a transvaginal exam or ultrasound. Uh, okay. Uh, Stabilize patients with a premature fetus, provide active surveillance, give tocolytics, use serial ultrasonograms to assess fetal growth, resolution of partial previa, administer betamethasone at 28 to 32 weeks to help with fetal lung maturity, deliver by C-section. Indications for delivery include labor, life-threatening bleeding, fetal distress, documented fetal lung maturity, and 36 weeks. Complications: risk for placenta accreta, vasoprevia, preterm delivery, PROM, FGR, congenital anomalies. Recurrence risk here is 4% to 8%. Okay, and let me grab a photo for this. So I just realized they have the photo for these down here. So yeah, normal placenta, placenta previa, vesa previa is with the vessels are seen through the ostium, closed, closing the ostium, and placenta abruption. So right there, this is the accreta. Accreta means attached, okay, to the myometrium. So in normal placenta, you have serosa, myometrium, endometrium right here. Okay, um, so it attaches to that. In placenta accreta, it attaches to the myometrium. In placenta increta, it invades the myometrium, and placenta percreta, it perforates the myometrium. Okay, so this is the placenta. So that's what they're talking about there. Because they mentioned placenta accreta here. Okay. So back to visa previa. Now we know what that is. Pathophysiology. Filamentous umbilical cord insertion and or bilobed placenta causing vessels to pass over the internal ostium. Incidence is 1 in 2500. Risk factors are multiple gestation, in vitro fertilization, accessory placental lobes, single umbilical artery, placenta previa, low-lying placenta. Symptoms: painless bleeding at rupture or membranes with fetal bradycardia. Okay, so these both have painless bleeding at rupture of membrane. So this bleeding is because of rupture of membrane with fetal bradycardia. Okay, this one didn't explain. Okay. Diagnosis: transvaginal ultrasonography with color Doppler showing vessels passing over the internal ostium. Management: acute bleeding, emergency C-section delivery. Diagnosis before bleeding: steroids at 28 to 32 weeks to help with fetal lung maturity. Hospitalization at 30 to 32 weeks for close monitoring and scheduled C-section delivery as clinically indicated. And complication here is fetal exsanguination. Okay. Okay, so management for acute emergency C-section. Diagnosis before bleeding. Steroids at 28 to 32 weeks to help with fetal lung maturity. Okay, so that is important. Hospitalization at 30 to 32 weeks for close monitoring. Okay. And scheduled C-section delivery as clinically indicated. QQQ. Other causes. Other forms of abnormal placentation, see later. Ruptured, ruptured, ruptured uterus, genital tract lesions, and trauma. Abnormal placental implementation. Okay, results from an abnormality of the decidua bacillus and is an important risk factor for postpartum maternal hemorrhage. Placenta accreta, abnormal implantation of the placenta such that the placenta villi are attached to the myometrium. Placenta increta is abnormal implantation of placenta such that the placenta villi penetrate the myometrium. Um, I like invade better, so you remember which one it is from the name. Don't do penetrate. Penetrate, use that for percreta. So placenta percreta, abnormal implantation of the placenta such that the placenta villi penetrate through the myometrium and into the serosa. So increta invades the myometrium, accreta attaches to the myometrium, percreta perforates the myometrium. Okay. Risk factors: prior uterine incisions, C-section, fibroid removal, okay, low-lying placentation, placenta previa, fetal Down syndrome. Complications: maternal hemorrhage, fetal asphyxiation, and death. Okay. Key fact here is with third trimester bleeding, think anatomically. Vagina, if it's from there, then vaginitis, vaginal lesion, trauma, cervix, bloody show, labor. Okay, so bloody show, um, cervical lesion, trauma, placenta, placental abruption, placenta previa, fetus, fetal bleeding. Okay, so you gotta think If there's bleeding in third trimester, then vagina, cervix, placenta, fetus. Okay, so you got to think of all these differentials when you're doing that. Multiple gestation. Multiple gestation affects 3% of all live births since 1980. The incidence of monozygotic identical twins has remained steady, whereas the incidence of dizygotic fraternal and high order births has increased. History and physical examination uh, characterized by rapid uterine growth, excessive maternal weight, and palpation of three or more large fetal parts on Leopold maneuver. Uh, Diagnosis: uh, ultrasonography, beta HCG, human placental lactogen, and maternal serum AFP elevated for gestational age. Okay. Treatment: multifetal reduction and selective fetal termination options for higher order multiple pregnancies, antepartum fetal surveillance for FGR. Okay. Complications: maternal. Patients 6 times more likely to be hospitalized with complications of pregnancy, increased incidence of placenta previa, and need for C-section delivery. Fetal twin-to-twin transfusion syndrome, most common in monochronic chorionic twins. Cord entanglement, commonly in monoamniotic twins. FGR, preterm labor, and increased incidence of congenital malformations. Okay, fetal growth restriction, a EFW. What's EFW? Did I miss that? An EFW less than 10th percentile for GAO. Embryonic fetal width, weight. We don't do weight, so probably width, I guess. And EFW less than 10th percentile of GA. History and physical examination. Risk factors include maternal systemic disease leading to uteroplacental insufficiency, intrauterine infection, hypertension, anemia, maternal substance use, placenta previa, multiple gestation, uh, symmetric fetal growth retardation, restriction, um, results from aneuploidy, congenital anomalies, and intrauterine infection. This usually occurs in the first trimester. Asymmetric FGR, head sparing growth lag. Okay. Results from uteroplacental insufficiency, maternal hypertension, or other maternal chronic disease. This usually occurs in second, third trimester. Okay, so symmetric FGR uh, usually occurs in first trimester, and one where the head is normal, but the rest of the body is asymmetric. That happens in second to third trimester. Okay. Diagnosis: best initial test, ultrasound to confirm gestational age and fetal age weight. Okay. Okay, so they do fetal weight then. Okay. Uh, Antepartum cerebrovundal height measurements with ultrasonography and weekly biophysical profiles, umbilical artery Doppler velocimetry. Treatment: explore the underlying etiology and corrective possible. If the patient is near due date, administer steroids, for example, betamethasone, to accelerate fetal lung maturity. This treatment is required 48 hours before delivery. Perform antepartum fetal monitoring. A non-assuring status near term may prompt delivery. Complications: increased prenatal morbidity and mortality. Fetal macrosomia, a birth weight more than 95%, um, a common sequelae of gestational diabetes due to fetal hyperglycemia. Okay. Fetal macrosomia. What is macrosomia? It refers to growth beyond a specific threshold regardless of gestational age. In high-income countries, the most commonly used threshold is a weight above 4,500 grams. Okay, so 9 pounds, uh, 15 ounces. But weight above 4,000 gram is also commonly used, which is 8 pounds, 13 ounces. Okay. So again, fetal macrosomia, a birth weight more than 95th percentile, a common sequelae of gestational diabetes and due to fetal hyperglycemia. Diagnosis: best initial test, US to estimate fetal size. Most accurate test is weighing the newborn at birth. Prenatal diagnosis is imprecise. Treatment: consideration of planned C-section delivery for a uh, EFW, so fetal weight, embryonic fetal weight. I still don't know what that is. More than 5,000 grams in a pregnant patient without DM, and for a EFW, more than 4,500 grams in a pregnant patient with DM. Okay, so more than 5,000 in without DM, and more than 4,500 in patient with DM. Okay. Complications: increased risk for shoulder dystocia, leading to brachial plexus injury and Herb Duchenne palsy as birth weight increases. Polyhydramnios, amnios, an amniotic fluid index (AFI) for more than 424 or more, or single deepest pocket 8 centimeters or more on ultrasonography. Okay. uh, may be present in normal pregnancies, but fetal chromosomal development abnormalities must be considered. Etiologies: maternal diabetes mellitus, multiple gestation, isoimmunization, pulmonary abnormalities, for example, cystic lung malformations, fetal gastrointestinal tract anomalies, for example, duodenal atresia, tracheoesophageal fistula, and encephaly. Uh, twin transfusion syndrome, history and physical examination. Okay. Usually asymptomatic. I think I was looking for a renal cause here. There's no renal cause for polyhydra. Oh, right, that was oligohydramnios. Okay. Um, I was thinking of the Potter syndrome. Okay. Diagnosis: sonographic documentation of excessive amniotic fluid volume defined as an AFI greater than or equal to 24 centimeter, or a single deepest pocket greater than or equal to 8 centimeters. Additional evaluation should include ultrasonography for fetal anomalies, glucose testing for DM and RH screen. May note fundal height greater than expected GA. Treatment: therapeutic serial amniocentesis to remove fluid from severe symptomatic polyhydramnios with shortness of breath. Treatment of underlying cause if possible. Complications: preterm labor, fetal malpresentation, and cord prolapse. Oligohydramnios, amnios, and AFI less than 5 or on ultrasound, or largest visible pocket less than 2 centimeters. Oligohydramnios is usually asymptomatic, but FGR or fetal distress may be present. Etiologies: fetal urinary tract abnormalities, for example, renal agenesis, gastrourinary obstruction, uh, chronic uteroplacental insufficiency, post-term pregnancy more than 41 weeks, rupture of membranes. Diagnosis: the sum of the deepest amniotic fluid pocket in all 4 abdominal quadrants on ultrasonography. Treatment: rule out rupture of membranes. Treat the underlying cause if possible. Complication. Okay. Post-term pregnancy also. Okay. Okay, so here the sum of deepest amniotic fluid pocket in all four quadrants on ultrasonography is how you diagnose that. Okay. Complication. Treatment will have rupture of membrane, treat until okay. Complication associated with a 40-fold increase in perinatal mortality. Other complications: musculoskeletal abnormalities, clubfoot, facial distortion, pulmonary hyperplasia, umbilical cord compression, and fetal growth restriction. Okay, so here we have maternal antibodies. Okay, so now we're changing gears here onto RH. So maternal antibodies from RH iso immunization at the time of the previous delivery cross the placenta and cause hemolysis of RBCs in the fetus. Okay, so here we have a Rh negative mother before pregnancy. Okay, and then she gets pregnant and the baby is Rh positive. So Rh positive fetus in Rh negative mother, right? So the Rh positive gets transferred into the maternal blood. So fetal Rh positive are red blood cells in the maternal circulation. Okay, so now the mother creates the antibodies to those. Okay, and she has, after the pregnancy, she will have the leftover anti-Rh antibodies. Okay, so after delivery, the mother develops antibodies to Rh antigen. And then Rh positive fetus in the next pregnancy comes along, and here you have the hemolytic disease of the newborn. Okay, because of that. So to prevent this, we give anti-D, so it's basically anti-Rh antibodies. Okay. So Rh iso immunization, fetal RBCs leak into the maternal circulation, and maternal anti-Rh IgG antibodies form. Yes, and you gotta remember that it's IgG, not IgM, because it's very specific. So antibodies form that can cross the placenta, leading to hemolysis of fetal Rh positive RBCs, erythroblastosis fetalis. Okay, that's when you get that. Rh isoimmunization occurs only in Rh negative women. Increased risk with previous spontaneous abortion or therapeutic abortion, or previous delivery with no RHO, so that's D antigen, immunoglobulin given. Okay, so in all of these conditions, you can have Rh immunizations. Okay, uh, diagnosis: sensitized Rh negative pregnant patients with titers more than 1 to 16. Okay, anti-D antibody titers should be closely monitored for evidence of fetal hemolysis. Treatment: in severe cases, the physician should initiate preterm delivery. Before delivery, intrauterine blood transfusions can be given to correct a low fetal hematocrit. Prevention: if the patient is Rh negative and the other patient is Rh positive or the status is unknown, given Rh immune globulin at 28 weeks. Okay, give Rh immune globulin at 28 weeks. If the baby Rh positive, give the okay, so if the baby is Rh positive, give the mother Rh immune globulin postpartum. The dose is based on the Kyhauser-Betke test. Inadequate dosing can lead to alloimmunization. Yikes. Give Rh immune globulin to Rh negative mothers who undergo abortion or who have had an ectopic pregnancy, amniocentesis, vaginal bleeding, or placenta previa or placental abruption. Type and screening are critical. Okay. Complications: hydrops fetalis when fetal hemoglobin is less than 7 gram per deciliter, fetal hypoxia and acidosis, kernicterus, prematurity, and death. Okay. Antepartum fetal surveillance. In general, antepartum fetal surveillance should occur in pregnancies in which the risk for antepartum fetal demise is increased. Testing is initiated in most at-risk pregnant patients at 32 to 34 weeks or 26 to 28 weeks if there are multiple worrisome risk factors. The following assessments take place. Okay. Non-stress test interpretation. Okay. Reactive NST, normal response. Two accelerations in FHR over 20 minutes period. Okay. So two accelerations in FHR. What's FHR? Okay. They didn't mention it, so we'll just move past that. Over 20 minutes period. Okay. Oh, two accelerations in fetal heart rate, I think, over 20-minute period. More than 10 beats per minute for 10 seconds if uh, less than 32 weeks, and more than 15 beats per minute for 15 seconds over above baseline for more than 32 weeks. Non-reactive NST, non-stress test. Okay. Insufficient acceleration over a 40-minute period. Possibility for fetal heart rate accelerations to not occur because of any of the following reasons. Fetal sleeping, most common. Can use vibroacoustic stimulation to wake up fetus. Less than 32 weeks. Fetal CNS anomalies. Maternal sedative or narcotic administration. Follow up a non-reactive stress test with contraction stress test or biophysical profile. Okay. So antepartum fetal surveillance, uh, fetal movement assessment. Right? Okay. Assessed by mother as the number of fetal movements over 1 hour. On average, 2 hours required for a mother to register 10 fetal movements. Maternal report of decreased fetal movements should be evaluated by means of various tests. NST, performed with the mother resting in the lateral tilt position to prevent supine hypotension. Fetal heart rate, monitored externally, so that's FHR, monitored externally by Doppler along with a tocodynamometer, dynamo, okay, uh, tocodynamometer to detect uterine contractions. In NST, non-reactive acoustic stimulation used to wake up the fetus. See this table for NST interpretation. And here we have reactive non-stress test. Okay, so here there was an acceleration. Here the fetal movement, okay. And acceleration, so fetal movement here, got it. Doppler, okay. Contraction stress test interpretation. Um, Positive CST, contraction stress test, late deceleration after 50% of more of contractions in a 10-minute window raises concern about fetal compromise. Delivery is warranted. Not negative contraction stress test, no late or significant variable deceleration within 10 minutes and at least 3 contractions. Equivalent CST, intermittent late decelerations or significant variable decelerations. Okay. Um, Biophysical profile scoring. Component is normal finding and score. Non-stress test. Two accelerations, 15 beats per minute or more, lasting at least 15 seconds over a 20-minute period. 2 is normal, 0 is abnormal. Amniotic fluid volume. Okay, single fluid pocket is 2 or more centimeters, or amniotic fluid index. More than 5. Uh, Fetal, so 2 is normal and 0 is abnormal again there. That's for everything. Fetal movements, 3 or more general body movements. Okay. Fetal tone, 1 or more episodes of flexion extension of fetal limb or spine. Fetal breathing movements, 1 or more breathing episodes, 30 seconds or more. So CST, contraction stress test, performed in lateral uh, recumbent position. Fetal heart rate monitored during spontaneous or oxytocin-induced contractions, contraindicated in pregnant patient with preterm membrane rupture or known placenta previa, those with a history of uterine surgery, and in those who are at risk, high risk of for preterm labor. See this table for CST interpretation. Biophysical profile uses real-time ultrasonography to assign a score of 2 or 0 to 5 parameters: fetal tone, breathing, movement, amniotic fluid volume, and NST. Okay, so it's everything we went over here. Okay. 8 to 10, reassuring for fetal well-being. 6, considering equivocal, considered equivocal. Uh, Test repeated in 24 hours if fetus is less than 36 weeks, or delivery initiated if fetus is at term. 0 to 4, extremely worrisome for fetal asphyxia. Strong consideration should be given to immediate delivery if no other explanation is found. AFI, sum of the measurements of the deepest cord free amniotic fluid measured in each of the abdominal quadrants. Less than 5 centimeter oligohydramnios, amnios, 24 centimeters or more polyhydramnios. So that was amniotic fluid index. That's what that was. Sum of measurement of the deepest cord free amniotic fluid measured in each of the abdominal quadrants. If it's less than 5 centimeters, then it's considered oligohydramnios. And if it's 24 or more, then polyhydramnios. Okay, that's the sum. But if you're doing it in one place and with the deepest pockets, if it goes anywhere from 8 centimeters to more, then it's considered polyhydramnios, right? Umbilical artery Doppler velocimeter, velis, velocimeter, velocimeter. Okay, Doppler velocimeter. Cool. Um, Used only when fetal growth restriction is suspected. Normal, high velocity diastolic flow in the umbilical artery. If abnormal, then decreased, absent, or reversed and diastolic flow in umbilical artery. Okay. With fetal growth restriction, there is reduction and even a reversal of umbilical artery diastolic flow with oligohydramnios, AFI of less than 5 centimeters. Follow-up further workup is always warranted. Key fact here: a negative CST contractions stress test is good. A positive one is bad, right? Because positive means there is no reaction there, no reactivity. Mnemonic: when performing a BPP, test the baby man. Fetal tone, fetal breathing, fetal movement, amniotic fluid volume, non-stress test. Right, BPP was up here. Biophysical profile. Okay, and we do all of these for that. Non-stress test, amniotic fluid volume, fetal movement, fetal tone, and fetal breathing. Okay, so that's what they're telling you here. Fetal tone, test the baby, right? So test is tone, baby is breathing, man is M for movement, A for amniotic fluid volume, and N for non-stress test. Okay. Another key fact: Braxton Hicks contraction. These are irregular low-intensity contractions of the uterus without effacement or dilation of cervix. Okay. Normal labor and delivery. Definition and stages of labor. Labor is the process whereby contraction of the uterus are accompanied by progressive effacement, thinning, and dilation of the cervix, resulting in delivery of the fetus and placenta through the birth canal. Obstetric examination. Leopold maneuver are used to determine fetal lie, longitudinal or transverse, and, if possible, fetal presentation. Breech or cephalic. Cervical exam. Evaluate dilation, effacement, station, cervical position, and cervical consistency. Confirm or determine fetal presentation. Stages of labor. Okay, so we have stage, start, ends, nulliparous, multiparous, duration, and comments. First, latent and active. Okay, so the first stage, the latent one, it starts onset of labor to 6 centimeter dilation. Okay, duration, if it's nulliparous, then less than 20 hours. If it's multiparous, then less than 14 hours. Comment, prolongation seen with excessive sedation, hypotonic uterine contraction. Okay, so onset of labor to 6 centimeter dilation. Active, this is 6 centimeter dilation to complete cervical dilation, 10 centimeters. Okay, nulliparous, 4 to 6 hours takes, and for multiparous, 2 to 3 hours, 1.5 centimeters per hour. Okay. Comment, prolongation seen with cephalopelvic disproportion. Okay. So here was with excessive sedation or hypotonic uterine contraction. Here it's cephalopelvic disproportion. So that was the first stage, up to 6 centimeters. Dilation to complete cervical dilation, 10 centimeters. Okay. Second is complete cervical dilation into delivery of the infant. So in nulliparous, it's 0.5 to 3 hours, 30 minutes to 3 hours. And for multiparous, 5 minutes to 30 minutes. Comments, neonates going through all cardinal movements of delivery. Okay, and third stage, delivery of the infant to delivery of placenta. Okay, so here that is 0 to 30 minutes and 0 to 30 minutes for multiparous as well. Uterus contraction and placental separation to establish hemostasis. Fourth, delivery of the placenta to 1 to 2 hours after. Okay, that's the fourth. This is 1 to 2 hours for nulliparous, okay, and none for multiparous, okay. Comment, tone of the uterus established, expelling any remaining contents, augmented by breastfeeding. So first has two parts, the latent and active. Latent is from onset of labor to 6 centimeter dilation. From there, active to 6 centimeter to 10 centimeter cervical dilation. Second is where it's complete cervical dilation to delivery of the infant. Third is from delivery of infant to delivery of placenta, and then from delivery of placenta to 1 to 2 hour after is fourth stage. Okay, so for the latent, it's 20 hours or less, 4.4 to 6 hours or less. And for active, second is 30 minutes to 3 hours. Third is 30 minutes, and fourth is 1 to 2 hours. Okay. So we're doing obstetric examination. Continuing that, Determine fetal position through palpation of the fetal sutures and fontanelles. Uh, Conduct a sterile speculum exam if rupture of membrane is suspected. Determine station or engagement of the fetal head relative to a line through the ischial spines of the maternal pelvis. Negative station equals fetal head superior to this line. Positive station, uh, fetal head inferior to this line. Okay, so how do you determine station or engagement of the fetal head relative to a line through ischial spine? It has to be. So through the ischial spine of the maternal pelvis. So you draw a line there. If the fetal head is superior to this line, it's a negative station. If the fetal head is inferior to this line, it's positive station. Okay. Uh, Oxytocin and misoprostol are often used as aids in the delivery process for contraction augmentation and cervical softening. Adverse effects of oxytocin: hyponatremia, tachysystole, and hypotension. Fetal heart rate monitoring. Monitoring can be performed non-invasively with Doppler ultrasound or invasively with an electrode attached to fetal scalp, a method that yields more precise results but can only be used with ruptured membranes. Continuous electronic fetal heart rate monitoring has not been shown to be more effective than appropriate intermittent monitoring in low-risk patients. Okay, so continuous electronic FHR monitoring has not been shown to be more effective than appropriate intermittent monitoring in low-risk patient. Okay. Components of FHR evaluation: rate normal equals 110 to 160 beats per minute. Fetal heart rate less than 110 is considered bradycardia. Can be caused by congenital heart malformations or by severe hypoxia secondary to uterine hyperstimulation, cord relapse, prolapse, or rapid fetal descent. Fetal heart rate more than 160 is considered tachycardia. Causes include hypoxia, maternal fever, intraamniotic infection, and fetal heart rate. Okay, so 110 to 160 is where the normal heart rate lies for a fetus. Variability, fluctuations in the baseline FHR that are irregular in frequency and amplitude related to fetal cerebral activity. Absent variability indicates variability. Fluctuations in the baseline FHR that are irregular in frequency and amplitude related to fetal cerebral activity. Absent variability indicates severe fetal acidemia. Minimal variability, less than 6 beats per minute, indicates fetal hypoxia or the fetus effects of opioid magnesium or sleep cycle. Normal variability, 6 to 25 beats per minute. Marked variability is more than 25 beats per minute, may indicate fetal hypoxia may occur before a decrease in variability. Sinusoidal variability, concerning for serious fetal anemia, a pseudosinusoidal pattern may also occur during maternal mipyridine use. Accelerations, onset of an increase in FHR more than 15 beats above baseline to a peak in 30 seconds or less. Reassuring because they indicate proper function of fetal and autonomic nervous system. Decelerations, see this table. Mnemonic, veal chop. Variable deceleration, cord compression. Early deceleration, head compression. Okay, so variable deceleration, cord compression, and this early deceleration is head compression. Okay, so VEA is for acceleration, which is okay, and late deceleration is equal to placental insufficiency. Note, interpretation include maternal repositioning, amnion infusion, uh, amnio infusion, or delivery. Okay, so veal chop. core compression, head compression, okay, and P for placental insufficiency, okay. Okay, so again, acceleration, onset of an increase in FHR more than 15 beats per minute above baseline to a peak in less than 30 seconds, reassuring because they indicate proper function of fetal autonomic nervous system. Okay. See this table. Okay, so this will talk about that. Okay, let's talk about that before we go on to obstetric analgesia and anesthesia. Types of fetal deceleration. Okay, so type, description, etiology, and schematic. Um, Early type, a description, a visually apparent gradual onset to nadir to in more than 30 seconds, decrease in FHR with a return to baseline that mirrors the uterine contraction. Etiology, okay, so a visually apparent gradual decrease in FHR with a return to baseline that mirrors the uterine contraction. So onset is over here, contraction, uh, more than 30 seconds, okay, in, and nadir is decreased, and recovery, it goes back, okay. Etiology, head compression from the uterine contraction, which is normal. Late, okay, so in late, what happens? A visually apparent gradual decrease in FHR with return to baseline, whose onset, nadir, and recovery occur after the beginning, peak, and end of uterine contraction, respectively. Okay, so here we did the contraction. So we got a contraction here. Onset is from here after the peak, okay, and the peak, lowest peak of the response is after the end of the contraction, right? And then comes the recovery later. So etiology of this is utero-placental insufficiency and fetal hypoxemia. Okay, and then variable, an abrupt, visually apparent decrease in FHR, fetal heart rate, 15 beats per minute below baseline, lasting more than 15 seconds but less than 2 minutes. Okay, so we have contraction, so it could be here, here, here. Okay, any of these will cause are considered variable. So this is the one where if it stays below the baseline for 15 beats per minute, lasting more than 15 seconds, okay, and but less than 2 minutes, okay. So obstetric analgesia and anesthesia. Uterine contractions and cervical dilation result in visceral pain, descent of the fetal head, and pressure on the vagina and perineum result in somatic pain. Okay, pudendal block. Bilateral transvaginal injection of local anesthetic in and around pudendal nerve as it passes around ischial spine. Provides perineal anesthesia. Can be used in second stage of labor. Okay, the second stage was the one from 10 centimeter to delivery of um, the infant. Right, complete cervical dilation, which is 10 centimeters to delivery of infant. Epidural block. This is injection of local anesthetic in epidural space that blocks lumbosacral nerve roots. Can be used for either vaginal delivery or C-section. Complications. Transient hypotension from sympathetic blockade is a common complication and does not require treatment unless there are signs of shock. Spinal headache is another common complication if there is a dural puncture Epidural anesthesia can cause postpartum urinary retention. Urethral catheterization is diagnostic and therapeutic. Absolute contraindications to regional anesthesia, epidural, spinal, or combination include the following: refractory maternal hypotension, maternal coagulopathy, maternal use of once daily dose of low molecular weight heparin within 12 hours. These are complete contraindications to regional anesthesia. Okay, that's epidural, spinal, or combination. So hypertension, coagulopathy, or heparin. Okay. What are the other complications? Epidural anesthesia can cause postpartum urinary retention. Urethral catheterization is diagnostic and therapeutic. Spinal headache is one of them. If there is a dural puncture. Transient hypotension from sympathetic block. Okay. Untreated maternal bacteremia, skin infections over the site of needle placement, uh, increase in intracranial pressure caused by a mass lesion. Okay. Abnormal labor and delivery. Indication for C-section. See this table for indications for both elective and not indicated C-section deliveries, and agents such as sodium citrate, H2 blockers, and PPI should be used in the pregnant patient to decrease gastric acidity and prevent acid aspiration syndrome. Preterm labor. Okay, so here, key fact, preterm labor is equal to regular uterine contractions plus concurrent cervical changes at less than 37 weeks. Okay. So preterm labor, onset of labor between 20 to 37 weeks, the primary cause of neonatal morbidity and mortality. Risk factors include previous preterm delivery, greatest risk factors, multiple gestation, infection, rupture of membrane, uterine anomalies, for example, prior surgery, bicornuate uterus, polyhydramnios, placental abruption, poor maternal nutrition, and low socioeconomic status. Patients found to have a short cervix at less than 24 weeks are at high risk for preterm labor. Most patients have no identifiable risk factors. History and physical examination presents with menstrual-like cramps, onset of low back pain, pelvic pressure, and new vaginal discharge or bleeding. Diagnosis requires the following: regular uterine contractions, 3 or more contractions of 30 seconds each over a 30-minute period, concurrent cervical changes at less than 37 weeks, assessment of contraindications to tocolysis such as infection, non reassurance, assuring fetal testing, and or placental abruption, sterile speculum exam to rule out rupture of membrane, ultrasonography to rule out fetal and or uterine anomalies, verify gestational age, and assess fetal presentation and amniotic fluid volume. Cultures for chlamydia, gonorrhea, and group B streptococcus, also urine analysis and urine culture. Indications for C-section, maternal factors, fetal and maternal factors, and fetal factors. Okay, we're talking about indications for C-section. So in maternal factors, they are prior classical C-section, vertical incision predisposes to uterine rupture with vaginal delivery, active genital herpes infection, cervical carcinoma, maternal trauma, demise, HIV infection with viral load more than 1,000 copies per ml, and prior transverse C-section relative indication. Fetal and maternal factors, cephalopelvic disproportion, the most common cause of primary C-section. Placenta previa, placental abruption, failed operative vaginal delivery. Okay. And fetal factors, fetal malposition, for example, breech presentation, shoulder presentation, non-reassuring fetal heart rate pattern, and cord compression prophylaxis. Okay, so All of these are indications for C-section. Okay, so back to preterm labor. The treatment is tocolytic therapy, beta agonist, magnesium sulfate, uh, calcium channel blockers, CCBs, prostaglandin inhibitors if less than 34 weeks gestation unless contraindicated. Magnesium for cerebral palsy prophylaxis if less than 32 weeks. Okay. Uh, Steroids to accelerate fetal lung maturity. Penicillin or ampicillin for GPS prophylaxis of preterm delivery is likely. Complications: respiratory distress syndrome, intraventricular hemorrhage, apnea of prematurity, patent ductus arteriosus, necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia, and death. Rupture of membranes, distinguished as follows. Spontaneous rupture of membrane occurs after or at the onset of labor. Premature rupture of membrane, PROM, okay, occurs more than 1 hour before onset or labor. This is a variant of normal at term or may be precipitated by vaginal or cervical infections, abnormal membrane physiology, or cervical insufficient. Preterm PROM. Okay, so preterm premature rupture of membrane. Rupture of membrane occurring at less than 37 weeks. That's what it's called, okay. Occurs, so PROM occurs more than 1 hour before onset of labor. This is variant of normal at term or may be precipitated by vaginal or cervical, okay. Prolonged ROM, rupture of membrane, occurring more than 18 hours before delivery. Okay, these are going to be tough to remember at one go. This is going to require revision. Okay, so rupture of membrane occurring more than 18 hours before delivery. Risk factors: young maternal age, smoking, and sexually transmitted infections. Okay. History and physical examination. Patients often report a gush of clear or blood-tinged amniotic fluid. Uterine contractions may be present. Okay. Diagnosis: sterile speculum. Examination reveals pooling of amniotic fluid in the vaginal vault. Nitrazine paper test is positive. Paper turns blue, indicating alkaline pH of amniotic fluid. Fern test is positive. A ferning pattern is seen under a microscope after amniotic fluid dries on a glass slide. Ultrasonography assesses amniotic fluid volume. If diagnosis is uncertain, ultrasonography guided transabdominal installation of indigo carmine dye can check for leakage. Unequivocal test. Minimize infection risk. Do not perform digital vaginal examination on pregnant patients who are not in labor or for whom labor is not planned immediately. Check fetal heart tracing, maternal temperature, WBC count, and uterine tenderness for evidence of intrauterine infection. Key factor here: to minimize the risk for infection, limit digital vaginal examination on patients, on women with premature rupture of membrane. Treatment here is depends on gestational age. Term: first check GBS status and fetal presentation, then the labor may be induced or the patient can be observed for 6 hours. 34 to 36 weeks. Labor induction may be considered. Less than 32 weeks. Institute expectant management and hospitalization for close observation of fetal well-being and monitoring for signs and infection. Antibiotics to prolong the latency period in the absence of infection. Antenatal corticosteroids: give betamethasone or dexamethasone for 48 hours, which promote uh, fetal lung maturity in the absence of intraamniotic infection before 32 to 36 weeks. If signs of infection or fetal distress develop, the physician should give antibiotics, ampicillin, and gentamicin, and induce labor. Complications: preterm labor and delivery, intrauterine infection, um, placental abruption, and cord prolapse. Okay, all of these. Failure to progress. Associated with intrauterine infection, occiput, posterior position, nulliparity, elevated birth weight, and maternal obesity. Okay. Diagnosis: first stage protraction or arrest. Labor that fails to produce adequate rates of progressive cervical change. Prolonged second stage or arrest. Protraction or arrest of fetal descent. Most commonly caused by malposition. See this table for definitions based on parity and anesthesia. Treatment is this. Complications: intrauterine infections may lead to fetal infection, pneumonia, and bacteremia. The risk for postpartum hemorrhage is 11%. That of fourth degree laceration is 3.8%. Failure to progress. Stage definition and treatment. First stage, failure to have progressive cervical change, latent, primiparous and multiparous. Primiparous is more than 20 hours, and multiparous more than 18 hours. Okay, treatment here is therapeutic rest via parenteral analgesia, oxytocin, amniotomy, and cervical ripening. Okay. Active: dilation of at least 6 centimeters and either no change in dilation with 4 hours of adequate contractions or no change in dilation with 6 hours of inadequate contraction. Treatment here is amniotomy, oxytocin, C-section if the previous interventions are ineffective. Second stage, arrest of fetal descent. Primiparous, more than 2 hours, more than 3 hours with epidural. And multiparous, more than 1 hour and more than 2 hours with epidural. Treatment here is close observation with decrease in epidural rate and continued oxytocin, assisted vaginal delivery, forceps or vacuum, and C-section. Okay, augmentation with oxytocin should be considered when contraction frequency is less than 3 in a 10-minute period, or intensity of contraction is less than 25 mmHg above baseline. Okay, intra-amniotic infection. Intrauterine infections occur via ascending polymicrobial disease from the vagina through the amnion, placenta, and uterus. Less commonly, hematogenous spread, transplacental seeding from a specific systemic maternal infection. For example, listeria can also occur. The following sections refer only to ascending infections, often called chorioamnionitis. Risk factors: premature preterm premature rupture of membrane, prolonged rupture of membranes, prolonged labor, internal fetal uterine monitoring device, repeated vaginal examinations, complications: postpartum hemorrhage, endometritis, preterm birth, neonatal pneumonia, and encephalopathy. Treatment here is broad spectrum IV antibiotics, ampicillin, gentamicin, clindamycin, and augmentation of labor. Okay, fetal malpresentation. Okay, this is any presentation other than vertex, that is head closest to birth canal, chin to chest, occiput anterior. Chin to chest, okay, or occiput anterior. Risk factors include prematurity, prior breech delivery, uterine anomalies, for example, fibroids, polyhydramnios or oligohydramnios, multiple gestations, PPROM, hydrocephalus, encephalopathy, anencephaly, and placenta previa. Okay. Uh, History and physical examination. Breech presentations are the most common form and involve presentation of the fetal lower extremities or buttocks into the maternal pelvis. See this figure. Subtype include the following: frank breech, 50% to 75%. The thighs are flexed and the knees are extended. Foot-long breech, 20%. One or both legs are extended below the buttocks. Complete breech, 5% to 10%. The thighs and knees are flexed. Treatment follow up to 75% spontaneously change to vertex by week 38. Okay. Um, External cephalic version. Uh, if the fetus has not reverted spontaneously, a version may be attempted by applying direct pressure to the maternal abdomen to turn the infant to the vertex. The success rate is roughly 50%. Risks of version are placental abruption and cord compression, so the physician should be prepared for an emergency C-section if needed. This is frank breech. This is single footling breech. And this is the complete breech. Okay. Key fact: breech presentation is the most common fetal malpresentation. Okay. Trial of breech vaginal delivery. Attempt trial only if delivery is imminent. Complications include cord prolapse and/or head entrapment. Elective C-section recommended given the lower risk for fetal morbidity. Umbilical cord prolapse occurs when cord presents ahead of fetal parts and protrudes through the cervix. Uh, Considered an obstetric emergency. Risk factors include rupturing membrane without engaged fetal head part, malpresentation, prolonged labor, and polyhydramnios. Diagnosis, visualization, or palpation of the umbilical cord ahead of fetal presenting part can be accompanied by abrupt, severe, prolonged deceleration. Treatment here is manual in elevation of the presenting part, call for assistance, and preparation for emergency delivery. What if you're the one being called for assistance? You don't know what to do. Shoulder dystocia. Okay. Affects 0.6% to 1.4% of all deliveries in the United States. Risk factors include obesity, diabetes, suspected fetal macrosomia, history of an infant with macrosomy, post-term pregnancy, and history of prior shoulder dystocia. Uh, Diagnosis: ruptured, diagnosed by a prolonged second stage of labor. Okay, that's the one from complete dilation of cervix to delivery of infant. Retraction of the head from the perineum. This is turtle sign. Okay. Treatment here is: in the event of dystocia, the following maneuver may be attempted. Meg Roberts maneuver. Let's see this figure. Okay. Figure 2.10 to 10. Okay. So leg elevation, Meg Roberts maneuver, and application of suprapubic pressure. So what happens here is, okay, the leg is lifted up and pushing downwards. Okay. Uh, flex, Flexing the hips against the abdomen. Okay, so you're pushing the leg against the abdomen. The leg positioning illustrated here can be used to assist in a delivery where the infant is at risk for shoulder dystocia. Suprapubic pressure may cause reduction of a shoulder dystocia through adduction of the anterior shoulder. Okay. Fundal pressure should be avoided in shoulder dystocia as it may cause further impaction of the anterior shoulder against the pubic bone. Okay, so like that. Cool. Application of the suprapubic pressure. Internal rotational maneuvers used if external maneuvers have failed to reduce the dystocia. The maneuvers reduce the diameter of the fetal shoulder girdle through abduction of the anterior shoulder towards the fetal back wood screw, or adduction of the anterior shoulder towards the fetal chest Reuben, by the fingers of one hand introduced intravaginally. Delivery of posterior arm, intentional fracture of the fetal clavicle, proctoepiciotomy, uh, Zeminelli maneuver, manually pushing delivered fetal head into uterus and taking patient for C-section. Excessive traction on the fetal head to delivery the anterior shoulder can result in stretch injuries to the C8 and T1 brachial plexus, including Horner syndrome, Erb-Duchenne palsy, and palsy, uh, Klumpke palsy. These brachial plexus injuries usually resolve spontaneously. Episiotomy, okay, surgical extension of the vaginal opening into the perineum can be median, midline, or mediolateral. Complications: extension to the anal sphincter, third degree, or rectum, fourth degree, more common with midline episiotomy. Others: bleeding, infection, dyspareunia, rectovaginal fistula formation. Routine use of episiotomy not recommended. Uterine inversion. An uncommon cause of postpartum hemorrhage. And this occurs when the uterus fundus prolapses through the cervix and vagina and can often be visible as a shaggy mass protruding from the vagina. The fundus is no longer palpable and the patient is usually experiencing severe abdominal pain. Causes include excessive fundal pressure and traction on the umbilical cord. Treatment involves discontinuation of uterotonics, manually replacing the uterus and monitoring hemodynamic status. Uterine rupture, very rare but life-threatening complication that may occur in pregnant patients with a history of C-section, especially vertical C-section or other uterine surgeries, may result in postpartum bleeding. Loss of fetal station is pathognomic for this condition, and fetal parts may be palpable in the abdomen but not in the vagina. Treatment involves emergent laparotomy. Okay. Puerperium. Okay. Uh, Normal changes after delivery include lochia, this is vaginal bleeding, uterine contraction, and uterine involution. The superficial layer of the endometrial deciduous shed through the vagina for the first 3 postpartum weeks. This is called lucia. For the first few days, lucia is red in color, lucia lubra, and then it changes to pink in color, lucia serosa. Lucia changes to white color, lucia alba, by the end of the second week. Postpartum urinary retention is also common and it is caused by bladder atony. This can be managed with catheterization and encouragement of ambulation, and it usually resolves spontaneously. Radiating suprapubic pain exacerbated by weight bearing may occur because of diastasis of the pubic symphysis, separation of the pubic bones. This is more common after a traumatic delivery, and treatment is with supportive care. Postpartum hemorrhage, a loss of more than a loss of 1,000 ml or more in the first 24 hours after C-section or vaginal delivery. Table summarizes common causes: signs of delayed postpartum hemorrhage, uh, saturating more than 1 pad per hour for 2 consecutive hours, passing large clots, Signs and symptoms of anemia: low hemoglobin, dizziness, and lightheadedness. Complications: anemia caused by chronic blood loss, predisposes to puerperal uh, infection, Sheehan syndrome, discussed later. Uh, Postpartum infection: a temperature of 38 degrees Celsius or more for at least 2 hours, 2 of the first 10 postpartum days, sorry, not including the first 24 hours. Okay. Okay, let's do this first. Common cause of postpartum hemorrhage: variable, uterine atony 80%, um, genital tract trauma 15%, and retained placental tissue 5%. Okay, so for uterine atony, uh, uh, risk factors: uterine overdistension, multiple gestation, macrosomia, polyhydramnios, exhausted myometrium, rapid or prolonged labor, oxytocin stimulation, uterine infection, conditions interfering with contractions, anesthesia, magnesium sulfates. Diagnosis: palpation of a soft, enlarged bogey uterus, most common cause of postpartum hemorrhage. Treatment with for all uterine causes. When bleeding persists after conventional therapy, uterine internal iliac artery ligation, uterine artery embolization, or hysterectomy can be life-saving. Other rare causes of postpartum hemorrhage are disseminated intravascular coagulation and uterine inversion. Okay, treatment: bimanual uterine massage, usually successful. Oxytocin infusion, methylgonowin if not hypertensive, PGF 2 alpha. Uh, Genital tract trauma, 15%. Uh, Precipitous labor, operative vaginal delivery, forceps, vacuum extraction. Macrosomia, inadequate episiotomy, repair. Diagnosis: manual and visual inspection of the lower genital tract for a laceration more than 2 centimeters long. Treatment here is surgical correction of the physical defect. And retained placental tissue, placenta acreta, increta, percreta, previa, uterine leiomyomas, preterm delivery, previous C-section, and curettage. Diagnosis: manual and visual inspection of the placenta and uterine cavity for missing cotyledones. Ultrasound to look for retained intrauterine tissue. Treatment: manual removal of remaining placental tissue, curettage with sanctioning, carries risk for uterine perforation or scarring. Asherman syndrome. Okay, other rare causes of disseminated. Okay, risk factors for postpartum endometritis: emergent C-section, prolonged labor, multiple intrapartum vaginal exams, intrauterine manipulations, emergent delivery, low SES, young age, invasive fetal monitoring, prolonged ROM, bacterial colonization, and corticosteroid use. Diagnosis: diagnosed with blood cultures and CT, looking for a pelvic abscess. Treatment here is broad spectrum antibiotics and anticoagulation with heparin for 7 to 10 days. Key fact here is postpartum endometritis, fever more than 38 degrees Celsius, uterine tenderness, and malodorous Lucia. Treatment: broad spectrum empiric IV antibiotics, that is clindamycin and gentamicin, until patient has been afebrile for 48 hours, 24 hours for intrauterine infections. Add ampicillin for complicated cases. Complications: septic pelvic thrombophlebitis. Pelvic infection leads to infection of the vein wall and intimal damage, leading in turn to thrombogenesis. The clot is then invaded by microorganisms. Suppuration follows with liquefaction, fragmentation, and finally septic embolization. Septic pelvic thrombophlebitis presents with abdominal and back pain and a picket fence, fever curve, hectic fevers, with wide swings from normal to as high as 41 degrees Celsius, 105.8 degree Fahrenheit. That does not resolve despite antibiotic treatments. The physician should diagnose with blood cultures and CT looking for a pelvic abscess. Treatment calls for broad spectrum antibiotics and anticoagulation with heparin for 7 to 10 days. Mnemonic, the 7 W's of postpartum fever, 10 days post delivery. Womb, endomyometritis, wind, atelectasis, pneumonia, water, UTI, walk, DVT, pulmonary embolism, wound, incision, episiotomy, weaning, breast engorgement, abscess, mastitis, wonder drugs, drug fever. The 7 W's of postpartum fevers, 10 days post delivery, right? So it could be because of any of these: womb, wind, atelectasis, pneumonia, water, UTI, walk, DVT, pulmonary embolism, wound, incision, episiotomy, weaning, breast engorgement, abscess, mastitis, and wonder drugs like drug fever. Okay. Postpartum cardiomyopathy. Peripartum cardiomyopathy and hypertensive disorders of pregnancy are a rising cause of maternal mortality in high income countries. This topic is discussed in detail in the cardiology chapter. Sheehan syndrome, postpartum pituitary necrosis, pituitary ischemia and necrosis that lead to anterior pituitary insufficiency, secondary to massive obstetric hemorrhage and shock. History and physical examination. The primary cause of anterior pituitary insufficiency in adult females. Most common presenting symptom: failure to lactate, caused by decreased prolactin levels. Other symptoms: hypotension, weakness, lethargy, cold intolerance, and genital atrophy, and menstrual disorders. Diagnosis: best initial test, adrenocorticotropic hormone, ACTH, stimulation test. Most accurate test, MRI of the pituitary gland and hypothalamus to rule out tumor and other pathology. Treatment here is replacement of all deficient hormones. Some patients may recover thyroid stimulating hormone and even gonadotropin function after cortisol replacement alone. Lactation and breastfeeding. Physiology. During pregnancy, increase in estrogen and progesterone result in breast hypertrophy and inhibition of the action of prolactin on the breast. Okay, so hold on. Before we do that, let's look at the photo. Physiology of breast milk production. Okay, so we have anterior pituitary and posterior pituitary that releases oxytocin, goes to the breast to contraction of the myoepithelial cells. Okay, and suckling at the lactating breast will cause stimulation of hypothalamus to release more oxytocin and produce as well. Okay, so during pregnancy, increase in estrogen and progesterone result in breast hypertrophy and inhibition of the action of prolactin on the breast. Okay, after delivery of the placenta, hormone levels decrease markedly and prolactin stimulates the alveolar epithelial cells, activating milk production. Increase in prolactin will decrease luteinizing hormone and follicle stimulating hormone, causing anovulation and amenorrhea during breastfeeding. Periodic infant suckling leads to further release of prolactin and oxytocin. Oxytocin stimulates myoepithelial cell contraction and milk ejection. let down reflex, and promotes greater involution of the uterus postpartum. Colostrum, early breast milk, contains protein, fat, secretory immunoglobulin A, and minerals. Within 1 week postpartum, mature milk with protein, fat, lactose, and water is produced. High immunoglobulin A levels in colostrum provide passive immunity for the infant and protect against enteric bacteria. Other potential benefits of breastfeeding include the following: decreased incidence of infant allergies, decreased incidence of early infant upper respiratory infections and GI infections, facilitation of mother child bonding, maternal weight loss. Females who desire to suppress lactation should wear a supportive bra. Avoid nipple stimulation, apply ice packs to breast, and use non steroidal anti inflammatory drugs to reduce pain. Breast binding should be avoided as it increases risk for mastitis. Okay, here contraindications to breastfeeding are: in maternal, infectious are HIV, not a contraindication in resource poor countries. Active untreated tuberculosis, active varicella, and active herpes on breast. For infant, no infection is contraindicated. Non-infectious causes in maternal are chemotherapy, radiation therapy, active substance use, for example, cannabis, cocaine, PCP, certain medication, for example, tetracycline or chloramphenicol. For infant, it's galactosemia. Contraindications to breastfeeding. Breastfeeding has many benefits and should be encouraged when possible. Contraindication to breastfeedings are rare. See that table. Mastitis, breast abscess. Cellulitis of the periglandular tissue caused by nipple trauma from breastfeeding, coupled with the introduction of bacteria, usually Staphylococcus aureus, into the nipple ducts. History and physical examination. Symptoms often begin 2 to 4 weeks. Postpartum are usually unilateral and include breast tenderness, erythema, edema, of warmth, and possible purulent nipple discharge. Significant fever, chills, and malaise can also be seen. Diagnosis: differentiate mastitis from simple breast swelling. Infection is suggested by focal symptoms and increase in WBC count and fever. Treatment: continuation of breastfeeding to prevent the accumulation of infected material, or use of breast pump in patients who are no longer breastfeeding. Oral antibiotics: cloxacillin, cephalexin, amoxicillin, clovelunid, azithromycin, clindamycin, antipyretic, and NSAIDs to reduce inflammation. If no clinical improvements within 48 to 72 hours, evaluation with breast ultrasonography to assess for abscess if present. Treat abscess with incision and drainage. Breast engorgement occurs when milk production exceeds removal, which leads to bilateral firmness, fullness, tenderness, and warmth. Management calls for frequent breastfeeding, compresses, warm before and cold between feeds, and mild analgesics. If patient is not breastfeeding, management calls for suppression of lactation described earlier. Nipple injury due to poor latch, infant positioning, infection, and vasospasm. Presents with pain, bruises, cracks, blisters, and bleeding. Management with nursing technique, counseling, analgesia, and compresses. Localized plugged duct stasis in sorry stasis in milk ducts leads to painful tender lump. Clinical diagnosis: most cases resolve on their own. Galactoseo, milk retention Swiss due to duct obstruction. Okay. Presents as soft cystic mobile non-tender subareolar mass on examination, mainly clinical diagnosis. Milky fluid on fine needle aspiration, FNA, diagnostic and therapeutic. Complex mass on uh, ultrasonography, and indeterminate or fat fluid level on mammography, rarely indicated. Most cases resolve by themselves. Treatment is usually not indicated. And that's it. See you in the next one.